which is a treasure in heaven. So we see Matthew juggling around and handling quite a lot of things from different areas in chapter 6 of his narrative. He goes on now to encourage his audience, and he's telling them that, my dear brothers and sisters, do not worry. In other words, he has been addressing a lot of things which touches directly on the lives of his audience, and so much he has seen that these people have or go through a lot of worries. And the key text for me here this morning, and throughout these sessions that we shall be here, is generated from chapter 6, verse 33, where the gospeler encourages his audience by this verse which I will read. I will read. But seek first the kingdom of God and his righteousness, and all these things shall be added to you. That is the key text that we shall be running through all this period in this conference. And I would like to say that, ladies and gentlemen, we live in a world full of a lot of distractions and a lot of things, and people always run from morning to evening, the whole week, the whole month, the whole year, and we run throughout our lives chasing for a number of things. We want better careers as human beings. We are pursuing quite a lot of things. We want to gather wealth, and we also want social validation, and we are chasing for a lot of endless things in this world, and human beings will never be satisfied. You see, we are always up and down chasing for things. We'll never be satisfied. And one thing, as we look into this, I would want to bring out 2 points this morning which I feel that are very important as we focus on Matthew chapter 6 verse 33. Number one is a right relationship with God. As we chase for all these things, it's not bad to chase for all these things. Even me, I'm chasing for them. I've driven all the way coming to this conference. I had to come here because I received an invitation several weeks ago to be here. I'm here, and I wanted to do my best. So the question is, what is our relationship with our Maker? As you are seated in this hall this morning. And another gospeler comes in with another text, and that is Mark chapter 8, verse 36. And Mark says that, what good is it for someone to gain the whole world, yet he forfeit their soul? You see, we are chasing for so many things, but are we really conscious about the state of our soul? That is an important question here. What is your relationship with your Maker, with God? How much do you take time to worship, to pray? How much do you take time to be closer to your Maker? I know that many times, because of these, a lot of activities that which I'm talking about, a lot of commitments. You wake up in the morning, you go out. You don't even remember to pray. You don't even remember to tell God thank you. Because the life and breath that God has given you to enable you to be here, it is not because of your might. It is not because you've done so many precious things in this world. It is because God loves you. Are you getting me? God loves you. God loves me. And that is why we are here. So what is it that you are giving in return to God? He may not want so much from you. He only wants an appreciation, a thank you from you. And the next point, which is the last this morning, is love for others. And again, another gospeler here comes in, and that is John. So in John chapter 13, verse 35, By this, everyone will know that you are my disciples if you love one another. Do we love one another? A writer by the name Emmanuel Levinas, who had written so much about the concept of the other, says that, many a times we tend to focus on the self, so much on the self, that we forget about others. We want to glorify ourselves. We want to do so much around, but we despise others. How much do you regard your brother? How much do you regard your sister? I know in this world we want to leave legacies, so much. But how do you relate with other people? Do you highly regard them? Do you despise them? Do you take them as rubbish? Do you care about them? And ladies and gentlemen, this morning, I want to urge you to be very conscious about the other person seated next to you. And he says that, you see, I know that none of us here hate themselves. We all love ourselves. And if you see those who don't love others, and they are looking, or they want bad things to happen to others, take the other person to be you. Stand in front of the mirror. Look at yourself in the mirror. Do you hate the person you see in the mirror? Do you? I know you don't. You love the person you see in the mirror. In the same way you love the person you see in the mirror, love one another. And that is the greatest gospel for us today. Praise the Lord. May the Lord bless you and keep you this morning as we begin this conference. And that is my prayer for you. And it will be my prayer for you from today all through to the last day when we shall be converging here for the same. The Lord keep you and bless you once again. Amen.
So thank you very much, Reverend Dr. Okoth. At this time, we want to, as we reflect on those challenges and the words that he has spoken, let us now move to the next session. At this point, I would like to call upon the chair of Tich Trust, Professor Dan Kaseje, if he can come and give remarks as we wait for other participants from the county. Thank you. I see Siaya well represented. Thank you so much.
Distinguished guests, our partners, ladies and gentlemen, good morning. I was supposed to give these remarks after the arrival of our chief guest, but they seem to have been delayed, so we will proceed. The CEO has welcomed us and has introduced the theme of the conference and the sub-themes. Our focus and preoccupation is to address the issues that affect people's accessing health care. For about 45 years now, since 1978, the global community has been focused on what the agenda that we call Health for All. In 1978, the global community met at a place called Alma Ata and issued a declaration that every legitimate government should ensure that the citizens all have access to health care to the best possible status or well-being that is possible. In order to know whether we are making progress towards that goal, we need to measure. We need to measure that progress. And that progress is measured by counting how many people are able to access care out of the total number of people that we have. Unfortunately, in our region around the lake, we are told that those that can easily access care are no more than 40%. That the other 60% are caught up, are trapped in a vicious cycle of ill health and poverty. That 60% of households in this region, actually a community consultant I was talking to last night even raised it to 70%, are sick and are unable to access care because they are poor. And because they are sick, they cannot adequately engage in productive activities. They cannot adequately engage in productive activities, and therefore they become poor. So they are sick because they are poor, and they are poor because they are sick. And that cycle continues. And this is why the three sub-themes of our conference, first of all, today we start with measuring our progress. Where have we got to? And how can we use routinely collected data that we collect anyway as we provide services, to have a continuous understanding of how well we are performing towards health for all. And then tomorrow we will be concentrating on the heart of the matter. The heart of the matter is what I just said. Lack of income, lack of financial means limits access to care. And so we will be dwelling on how can we ensure sustainable financing that allows access to care for all. And then the other dimension which impacts health is food security, access to food. And so tomorrow and the day after, we shall also be reflecting on issues of climate change and how they impact on food and nutrition security. So that is in a summary of what we are going to be engaging in. I want to recognize the partners that we are together here with. We have partners from the UK, from Keele University, Professor Monica, and our colleague Krian, who have come all the way to be with us and to share with us how they have achieved health for all in the UK as we compare with our own situation to see what we can learn from each other. We have partners from the county of Siaya. We have partners from the county of Kisumu. And we have partners from Homa Bay and from Migori, and from other places. So please feel welcome. The categories of people that are here this morning include policymakers and service providers in the health sector and other sectors. We have researchers from various universities. I see Pwani University is represented, Nairobi University is represented, and others. So we have researchers. And then we have some very special people that I want for you to find out where they are and ensure that you hear their perspectives. I told them that they are the validators of what we shall be saying. That after the scientists have talked, that it is their responsibility to validate what the scientists have talked about, what the policymakers have said. Have they said things that are relevant to the context from which they come? These community consultants, we have them representing each county. So when you are talking here from science, using big words, I hope you recognize that there are community consultants among us who will be given chance to respond and tell us what you said was, yes, relevant, or what you said actually is what they call in football offside. You have said good things, but they've gone, it is not counted when it comes to real experience at the local community context level. So ladies and gentlemen, we are delighted that we are all here and that each one of us, we have a role to play, and that we shall use this time together to learn from each other and to continue to find solutions to some of those things that seem to limit our access to health for all. The program will have several types of activities. We shall have, as I said, experts sharing their thoughts as keynote presenters. We then shall have round table discussions and debates, particularly focusing on certain areas that are significantly impacting on access to health for all. And then after the roundtable discussions, we shall also have capacity building sessions towards the end of the day. There are those of us who would like to learn a bit more how to do certain things. And this year we shall be focusing on how to manage the data we always collect and use it to make sense of our progress in order that we can take decisions that help us to continue moving forward. So with those few remarks, I would want to, I don't know where we got to in terms of the opening ceremony. I'll listen to my boss to guide me as to whether to vacate. Sorry, I should have recognized that the CEC health from SIA has arrived, right? So. Yeah. Thank you, my boss. Yeah, thank you, Dr. Konyango from SIA has arrived. We are waiting for the Deputy Governor Kisumu to arrive so that together they partner in getting us off the ground started. Thank you very much for honoring our invitation and for coming in time. Thank you. Yeah, sorry, my eyes, you know, when I was younger, I would have recognized the CC. And now I have an excuse that eyes have kind of gone a little weak. Okay, we also have some partners from elsewhere. Among us is Mr. Yoni Otieno. Can you stand and wave, Yoni? We welcome you. Yoni is representing some partners from Canada. The partners from Canada come from an organization called Biomark Diagnostics, and Biomark Diagnostics seek to partner with us to introduce some new ways of enhancing diagnosis of health problems, and we are negotiating the possibility of partnering in Siaya if we are welcome at a particular site in Siaya, which we already discussed with the CEC. And these colleagues are here represented by Yoni, but we also have a colleague who is in Canada and would like to address us to introduce their organization. And hopefully, if acceptable, this morning we might sign an MOU to work together to develop diagnostics in Siaya. So if the technology allows, I will then invite, if technology allows, I will invite Mr. Rashid Ahmed to speak to us remotely, and if he doesn't come through, then Yoni will take his place, even as we continue to wait for the DG. Are we able to,
Thank you.
To allow Rashid to address us?
I'm right here. Hi, Prof. I'm right here. Can you hear me? Hi, Prof. Can you hear me?
Who is supposed to help me with that? Otherwise, I'll invite Yoni to come and just say a few words about Biomark in terms of introduction.
Greetings to everyone and good morning. Yes, like Prof has said, my name is Yoni. I know we are waiting to have our technical resolved so that my colleague Rashid can also get a word with you. We are very much excited and looking forward to these 2 days together, and for the reasons of healthcare and how we can improve those access. So what we've been looking at is why is access a challenge for most of us, and you realize that I'll give some case studies just to bring this point home, that in our community we don't get to live longer than those who are away from here. The sad truth is that those who are in Nairobi and other areas tend to live longer than most of us because they can have access to some of these things that hinder our longevity of life. So we've always tried to see how we can resolve this, and we realize that there are aspects of this that we can actually start to look at. One of them is how quickly can we test, diagnose, and and give care. So care is very essential to how someone is going to be managed, but you have to identify what are the conditions that are ailing our patients. So at Biomark, we have cutting-edge technology that can be used and exported for innovative testing. And one of these very high-level testing that we've looked at is diagnostic testing for cancer, specifically areas of breast cancer and areas of lung cancer. which again affect majority of us. But that doesn't stop there. The technology that we bring forth in this is also ability to access bioavailability testing that is able to identify what are the type of drugs that we are taking and are they taking care of us adequately. You can't be taking medication, but medication can also be toxic. If you go back to the basis of how drugs are defined, are actually definition of a drug is a poison. So you can only know that you're taking the right one if you can access how effective those drugs that you are taking and how well they are taking care of you. So we bring in those aspects of innovation. They are cutting edge. Through our leadership of Prof. Kaseje, we saw it right that we can actually start to bring in investors who are going to actually expand in our testing. And this is not only going to focus on counties around here, but we are looking at the 14 counties around the Lake region. Beyond that, we are also looking at doing testing that goes beyond into the 5 countries of East Africa. That is Kenya, Uganda, Tanzania, Rwanda, and DRC. Looking at where we are strategically located and no one can change that. And we are at the axis of the borders of either cross pandemics that we have to monitor, and we bring aspects of surveillance that can look at healthcare from a one-point shop that can be strategically located in this region. And this is the very motivation to look at how can we work with Tich to actually segment this testing and give our communities beyond our borders access to healthcare. So one of the technologies that we've identified that is going to help us achieve this is the technology that is at Biomark. And the ability to bring up testing and identify patients who needs care quickly before some of these cases can be taken up late and we lose patients or they become too expensive. So technology is one of the greatest motivation, and how technology is going to help us do this is through options of even including telemedicine. These are services that we are going to offer so that patients can continue to interact with doctors. I know within the healthcare structure, there are things that have always brought friction. And one of the hindrance to access to healthcare is the long queues that are at the hospitals that are really annoying, and some people feel that they don't have a way that they can access care because the health facilities are crowded and they are not going to have that privacy of care as much as they would have wanted. So the options of telemedicine that technology brings are some of the very offering that our technology platform is going to ensure that even when you are at home and you feel like you need to consult, then very fast your vitals can be taken, your doctor can review your, can triage you using telemedicine, and that actually minimizes the time that care has to be processed before it can be offered. So I'm just giving snapshots of what that looks like, but we know that even in testing, if you can make people test at home, then access to that process of giving care becomes more enabled and more friendlier to the patient, unlike when you're asked to go and do it elsewhere. So within those 5 options is how easy can care be accessed at the nearest place to the patient. That is one option. How can you use telemedicine as an option of care? And also, where else can care be accessed? We know very many of us go to the pharmacy to access care. Those are channels that we can still make as options that policy and framework can allow for care to be accessed. Because we know very well that we feel our pharmacies are some of the greatest stop points for people to access care. So we are giving people a number of options. You can set up tents and give care closest to the patient. And those are ways that we can improve access. Before I proceed, I would just want to ask the technical team if they were able to bring in Dr. Rashid Book from Canada, or that is still, so that at least he also has a chance to, let me just introduce Rashid.
Tony, I'm here.
Rashid is a Kenyan who left 30 years ago to go and work in Canada, and is actually the proprietor and the CEO of Biomark Diagnostics. Being a Kenyan Canadian, he's always loved to bring something back to the community that is actually and that actually where he started his life. And through the leadership that we've had from Prof. Kaseje, we thought that this is the perfect opportunity to bring something that is impacting, because Tich over the years has established resources that can be expandable, and the resources that they have is unmatched, and the location of our catchment area in terms of surveillance, giving care, diagnostic and testing is a perfect environment to allow us to do this. So I don't know whether Rashid will be able to talk to us.
I'm right here, Yoni.
So he's still troubleshooting that. But in the meantime, I'll think maybe I'll, all right. If there are questions there, we can, I'll be able to take questions. Or if there is, as we still wait for Rashid to be able to join us remotely.
Rashid.
So I'm being guided that we will just proceed. While I'll also just quickly introduce myself. My name is Yoni Otieno. I'm a medical microbiologist by training, and over the last 14 years, I've been involved in clinical research development in healthcare. I took initiative that were there to actually be part of the HIV prevention trial network that was being done across Africa to develop prophylaxis and treatments. And after that, I also had a chance to be involved in vaccine development for Ebola, and also testing of Ebola in West Africa. So I worked across a number of West African countries developing treatments for this Ebola when there was an epidemic then. And we were able to manage that and actually bring capacity and ensure that our continent was safe. And right now, I work with a technology company out of the US, and what we do, we are a public benefit corporation that work to bring public safety in all patients, because we know ultimately all of us seated here will be a patient someday. So we have to improve our healthcare system to take care of us when we become patients at that moment in time. So up to this point, I'll give it back to the master of ceremony, but I'll continue to have discussions with you.
Let's give him another hearty round of applause. Good morning, ladies and gentlemen. God is good, and all the times. My name is Madanji Bob. I'm the Chief of Protocol from the Governor's Office, Kisumu County. I bring you the greetings from the Governor, and we'll change the program for now. You allow me to invite the Director of Health from the County Government of Kisumu to make few remarks. Then thereafter, I'll invite the CC of Health from Siaya, who will now do the other activities on behalf of the Governor of Kisumu and of Siaya. Dr. Don Ogola.
Thank you very much, Director Protocol Madanji, for this opportunity and to speak, just give an opening remark at this conference. Good morning. My name is Dr. Goladon Sande, the Director of Medical Services in the County Government of Kisumu. Allow me first to recognize the part of the CHMT that I've come with. They will just rise up. So we have Zachary Okech, is the head of EOC. EOC is Emergency Operations Center. Thank you. And is Sirma Peter, is the Deputy County PHO, Kisumu County. So that is the team we've come with. I want to take this opportunity with a lot of humility to stand before you to just make some few remarks in this conference. As you know, number one, we are talking about the digitization of health system. Health system cannot be fully functional if we have not done fully digitization. As you know, there are pillars of health system. For health service to be given, we have 6 main pillars. However, there is 7th one which is being introduced, and this is what we call research and innovation. So currently, we are talking about 7 pillars of health system, and number 7 is research and innovation. That health system cannot be of good quality if there is no research component that attaches to it. That helps us to give what we call evidence-based medicine, evidence-based innovation, and evidence-based service delivery. Tich, which is here for this conference, we applaud you for taking important steps to bridge our gap of research and innovation. The Department of Health, Kisumu County, has a division called Research and Innovation. However, it is not still equipped or capacity built to do a lot of research that help us to improve on our service delivery. And that is reason why we are leveraging and collaborating with the existing colleges and the existing universities to help us bridge the gap of research and innovation to be part of our health system building blocks. So Tich, we applaud you. The in charge of Tich, that is the professor. Thank you for having the collaboration with us at the Department of Health. We've had several meetings with them because they are using the data to make us have informed decision, to make us have evidence based of what system and what health innovation we are supposed to put. So thank you so much, Tich, as a whole, as a college, because you bridge that gap that we still don't have the capacity to have it running, so that our service we are giving is of high quality. Number 2, as we speak, the government of Kenya is in the process of enacting quality service, health service, and patient-centered bill. The bill has passed what we call public participation, and now it is back to the parliament, and soon it will be assented by the president as a law. That means that all the health service delivery point will not only be giving services, but will be giving services of high quality. And the patient will have a right to tell the doctor or tell the nurse or to tell whoever that what you are doing to me is not of high quality. We are going to be more responsible. Before we reach that end, it is the responsibility of the service provision people in that space to improve on their service and quality, on their quality of service that they give. This can only be reached when the service is integrated with the research and all that pertains to the quality of the service that we are supposed to be giving. So Tich and those who are in the conference, thank you for being part of this space so that we can improve on our quality of the service that we give. Lastly, in the building block, health system building block, there is what we call the health system information, health information and records. It is one of the major building blocks of health system, that you cannot provide health system without records, without introducing the patient, without keeping the patient's record and using it, the data of the diseases or any other problem that they have, to make informed choices. We have not improved to 100 mark that we envisioned, but where we are leveraging and we are getting into collaboration with the research fields so that we can have an improved, streamlined, research-driven, and technology-driven, so that our records keeping, our health records are of what we call undebatable records that we can really rely on to make informed decisions. We, as Department of Health and the county government of Kisumu, expect that our research wing, like the Tich, will use our data, will use whatever we have to make us improve on what we are doing, both for decision making, both for budgeting process, both for informed human resource and personnel, so that we can improve on the service that we give. It is therefore important that our collaboration with the research institution go a long way, are strengthened, and are based on legal issues. That is what we call the memorandum of understanding, so that we can have a robust way of how we work together. We thank the Tich so much of where we've reached, and we believe that moving forward, Kisumu County as a whole, not only Department of Health, will have more fruits, will bear more fruits from our collaboration with you people. Thank you so much, and I'm sorry for not recognizing the top leadership from this. I hope the protocol has already been set, so thank you for that, and sorry for not recognizing the protocol that already been set earlier. Otherwise, thank you and be blessed.
I think he deserves a better round of applause than that. That was wonderful, isn't it? Now, I'll want us to be upstanding so that we welcome our guest of honor, who is wearing the shoes for the two governors and is equal to the task. Just let's warm up our hands as we get standing, please. Warm up, ready? Second, warm up, welcome. Dr. Makwenyango, welcome. Thank you.
I think I have been exalted, I've been uplifted, and you witnessed it. The Bible says you start down there, they bring you this side. Because when you go the other way, it's another story. I've also come to learn a few things. I think it was the representative of biomass who was here earlier, and he mentioned that drugs are poisoned. Maybe I heard it wrongly, but we are learning. So I was learning that we just take poisons. So I think it's a good moment to be alive. As you have heard, I've also been uplifted to represent two governors. This is a very big job. I wasn't prepared for that. And because I have to adapt very quickly, I have to take out this speech. I didn't want to use it, but because the responsibilities are too heavy, I must go to this to survive. To the CEO of Tich, Professor Dan Kaseje, to the directors, Kisumu Director Protocol and Director Medical Services, to the distinguished, I want to start with the distinguished partners and the distinguished guests and all invited guests, ladies and gentlemen, good morning. Prof. Kaseje, I want to allow me to write on whatever protocols that have been set, and it's only good to go by first introducing oneself. Maybe you might have learned something about me when I was down there. My name is retired Colonel Dr. Martin Konyango, and I am the County Executive Committee member for health. That is why there was a lot of attention down there. I am accompanied here by, I think SIA is quite well represented. I also have a director. I was trying to match Kisumu. My director, Kennedy Orwenjo, is County Director, Public Health. I know Dr. Gola is Medical Services. Allow me to just refer and read this speech. I'm supposed to do representation of the two governors. I was supposed to do a keynote address. I had only carried a speech. So this will serve for all those purposes. Are we together? It's a pleasure to join you at this important conference focused on data, digitization, and utilization for improved livelihoods, a theme that speaks directly to the heart of what we have been doing in Siaya County as partners to Tich. We have been partners for quite a while, and we are very glad and we are ready to continue working together. I stand before you representing my governor, senior counsel, Excellency James Orengo, and he has sent greetings to you. He is not here because of exigencies of work. All this was communicated. It's also an honor to be participating in this 17th Tropical Institute of Community Health Annual Scientific Conference, which is the 17th. Having carried it all the way to the 17th conference in itself is a big achievement for Professor and all the partners, including KIL. I'm told you have been working together all this time. Congratulations. I acknowledge and appreciate the milestone and achievements of Tich, including but not limited to strengthening community health systems. Today, data is widely recognized as critical tool for decision making, but recognition alone is not enough. Often, by the time data is analyzed, the opportunity for timely action is lost. Our focus in SIAA is to ensure real-time data is not just available, but actually used to guide decisions, save lives, and improve services. During the COVID-19 pandemic, SIAA County led the way nationally in developing an evidence-based response. Through digitized data collection and rapid analysis, we maintained one of the lowest infection and death rates in the country. That same digital system helped us maintain access to essential services like maternity care, antenatal care, and immunization by flagging disruptions early and guiding quick interventions. This success has inspired us to go full scale on digitizing our health systems. But we are not doing this alone. We are working closely with partners to build capacity for data collection, analysis, and real-time use at both facility and community levels. For this progress to be sustainable, we must ensure long-term financing for digital health infrastructure. And beyond health, we are using digital tools to monitor food security and impact of climate change, because nutrition, health, and environment are deeply interconnected. Ladies and gentlemen, data must move beyond dashboards. It must guide decisions, policies, and budgets. And most importantly, it must serve the people. And hence, the theme for this year's scientific conference. Finally, and this I repeat, accept the greetings and the best wishes from my governor of SIAA, the Senior Counsel, James Orengo. Thank you, and I wish you a productive conference. At this point, if you allow me, I'll declare this conference officially open.
I thought at that point would have been appreciating and shouting "Gala Gala" because it has been officially open. Let's try again. Let's go. Thank you very much, Dr. Martin Makonyango, for that wonderful speech you have delivered this morning on behalf of the two governors, and you are equal to the task. I want to believe that that is the more reason why you are elevated from where you are. The Bible says, humble yourself and you'll be exalted. And that is what Dr. Makonyango was trying to tell us. Now, at this point, we are going to witness the signing ceremony between Tich, Biomark Diagnostics Partnership, and I want to believe we are going to do it down there before we go in for the health break. Professor Margaret, can you help us on that now? Good. So, Professor, the partners. They come down. Kindly, please. Yes. In Kisumu, we say teach, tire, teach. Again, teach. And in Siaya, we say nyalore. Can we say? Asante sana. Kendo tumore. Kendo? Haya. On that note, allow me now to, on behalf of the CEO, to declare we go in for a health break. And then before we go for a health break, I'll call upon her to give us the next program after that. How long are we going in for a health break? Professor Margaret?
Yeah, so we take a break for 30 minutes to have a cup of tea. So that 10, we are back at 10:15 to continue with the next session. Thank you.
Mic check. Mandela, can you hear us? Mic check, 1, 2. Check 1 2. Mic testing. Mic check 1 2. Nile mtu aongee kwa mic, mtu aongee kwa microphone ndo nisikie pia mimi huku. Mic check 1 2. Nile mtu aongee kwa microphone.
Yes, we can hear you now. So as we prepare for Rashid to present later, can you hear me?
Mimi siwasikii, sijui kwa nini.
You can't hear me?
Mimi siwasikii.
Okay, let me set on my side alafu tuone.
I can hear you. Check 1 2. Mimi siwapati huku. Hata kama niangalie shida kwa.
Unanisikiza? Unanisikia? One mic check. Mic check 1 2. It's there. Mic check. Mic check. Mic check 1 2. 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 Mic check 1 2.
Check 1 2 mic check. Mandela. Shida ni wireless.
Check one, two. Check one, two.
Mic check. Mic check. Mic check. Mic check. 1, 2. Huh? Mic check. Mic check. Mic check. 1, 2. Mic check. Mic check. 1, 2. Mic check.
Check one, two. Check one, two.
Check 1 2. Check 1 2. Check 1 2.
Check 1 2. Check 1 2. Check 1 2. Check. 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 Iende kwa projection. Usirudishe tu test. Kwa sawa. Check 1 2. Check. Check 1 2. Check. Check 1 2. Check. Check 1 2. Check. Check 1 2. Check 1 2. Hiyo saa yote mnashuka ni kama mmeguza kitu. Check. Check. Check 1 2.
It's cooked eyes. First come the boy call me #1. I just wanna sing for my baby. But final I'm falling in love with you. I never felt so happy before you. Baby, you're the one in a million. Oscillation meal, I make a million. Promise I'll never leave alone. Never. You smell like a honey. You're the only one I wanna spend the rest of my life with you, my sweetie body. Oh, we never done it, we could do the rest of our life. Keep wanting love. Now sincere. Keep wanting love. Who's sincere? Baby Lala. Who's sincere? Keep wanting lala. Who's sincere?
Good morning once again. How come I cannot hear? Is it okay? Are you hearing me? If you are hearing me, clap once. Yes, then you have heard me. But I'm not feeling comfortable. Is it too high? Am I too short? Either it is too high or I'm too short. One of the two. So we want to welcome us to this session of the program. We started on a high note by people being elevated. Thank you, my minister. I'm born in Siaya, so I'm totally aligned to people being elevated. It is fine. So this session, we have some powerful people going to speak to us. Professor Dan Kaseje and Professor Margaret set the stage this morning, and they have gone through with us regarding the sub-themes, the theme and the sub-themes for the conference. The first day, we were told we are going to talk about digital health, and we have some powerful people to speak. What makes it more interesting is that one of the things we'll be hearing a lot from the project that we are doing with Kisumu and Siaya counties. That makes it practical. So we are not just speaking about theory, but we are putting theory to practice. The final analysis, we want to have a real conversation and debate about how digital health can support health systems and improve health outcomes in our counties. So we have gone through the themes and sub-themes, as I said, and we know from the beginning that health systems have always had issues. I've been in health for the last more than 40 years. Start by saying I'm Elizabeth Oyuer, formerly served as the Registrar of the Nursing Council of Kenya, formerly served as the Director of Nursing Kenya. Right now, I'm serving as Registrar of the College of Nursing in EXA. EXA has 19 countries, and I'm the Registrar. So I'm partly in Arusha and partly in Kenya. And I know about the health systems. We have had many challenges, and we think that digital health is going to be that magic bullet that is going to serve us well. But the elephant in the room has always been, there are many challenges. So is it going to solve all our problems, or it is going to bring even more complexity? So to help us discuss this matter, we have presentations lined up. They are in two sets. The first set will go up to 11:30. It's 1 hour. And it has three giants. And I'll call the giants up one by one. Ladies first. I'll start with Margaret Magadi. Monica Magadi. Please. Rashid is online. Round of applause for Monica Magadi. She's from Keele University in UK. Please come up front and have a seat on the nice seat set up here. Her profile is written very elaborately in the program book. Please read it. She's a Kenyan in the UK and just giving back to our society. Another round of applause for Monica. Then we have Martin Osumba is our other one who is going to help us answer these questions. He's a wonderful gentleman. We worked before when we were in the Ministry of Health, and right now he's doing many things that are also written in the program book. A round of applause for Martin. Finally, we have a young man also from Kiel University who came with Dr. Monica. He's called Kiran. Kiran is also from Kiel University. He's also coming to discuss with us on digitization. Please come forward. Martin and Kiran, just come. Round of applause for the gentlemen. Thank you. So each sub-theme keynote speaker will be given 20 minutes, but 20 minutes will swallow the whole hour. So if they can do 15 minutes each, so that we have a few minutes to discuss, it would also be okay. But if they take the 15, 20 is still okay. I'm informed that Dr. Rashid is on. Technology has allowed, and we wouldn't want him to wait. I know the signing has been done. He'll not pull out the signatures. We want to allow him to speak. I'm waiting for signal to tell me whether he's online already so that we can continue with him or go on with our presentations. And as they are consulting, the first two presenters, Monica and Martin, will speak about linkages between health system challenges and digital health interventions. Kiran will speak about health facility data quality assessment. The last presentations will be more practical, and Kiran will be coming back with somebody else. So we have up to lunchtime to engage and just discuss these issues. I'm giving 1 minute for them to come and tell us if Dr. Rashid is available for virtual presentation. We want to recognize the work of Yona, who was here earlier. It's a beautiful thing to come back and just give back to our societies. He's already speaking. Dr. Rashid, if you can hear me, lift up your hand. Looks like he can't hear me.
I can hear you.
Our Gen Zs and millennials, please help us. The rest of us who are born before computers, like Prof. Dan Kaseje, we are struggling. We are relying on you. Jerusha is coming with good news. Okay. Okay. I've been told 1 minute, so then it comes. Dr. Rashid, can you hear us?
I can hear you, yes.
Yes, please continue, speak to us. We've really been waiting to hear from you.
Yeah, thank you so much.
Yes.
Thank you so much, and congratulations for the 17th Annual Scientific Conference. I wish I was there. As Yoni mentioned, I was born in Kenya. And, you know, one of the burning things that I have in my life is to make sure that innovation that I've spent over 15 years can come to fruition in my own motherland. So just as a background, we at Biomark have been spending close to about 14 years perfecting the technology. So we understand the pains of research. And one of the key values of what we think is basically making sure we have good clinical research so we can do clinical validation. And then we can basically have really dynamic diagnostic tests. So I've been hearing on the background about the pains that people look at, making sure you have the right clinical design, you have the right regulatory framework, you have the right validation folks in there. So I've gone through that. And just to let you guys know, we conducted one of the largest lung cancer trial programs in North America. We finished the studies. The results are very, very encouraging. As Yoni mentioned, our technology platform is really focused on early detection of cancers, but it's versatile enough. So before I get into that, I wanted to, send my congratulations to Professor Kaseji. As you guys all know, he's a very dynamic person. I got to know him about 8 weeks ago, and I can tell you one thing, he has a dynamic vision. Backed by Margaret and the board, I think you guys are doing a fantastic job. We're a private company, we're publicly held, and one of the key things is obviously making sure we have the right due diligence. And I can tell you this, that Johnny and I were so impressed by Professor Kasaji and the kind of vision that he had. It kind of propelled me to make sure that I, partner with you guys. So on a bigger scale, we have active collaboration with AstraZeneca and Pfizer. So it gives you some kind of idea as to how people are envisioning our technology. So we've presented at major cancer symposium, American Society for Cancer Oncology, ASMO, European Society for Medical Oncology, the breast cancer symposiums, and Ontario. So all of this stuff is really kind of amplifying what we've been able to do. So within the next 6 weeks, we should have our lab certified to ISO 15189. And the reason I'm talking about that, because I think we can bring the same discipline to the lab facilities at Tich. As we all know, that Tich is not a small idea. I think it has the bandwidth to really increase capacity, health capacity, training, highly qualified personnel training. But we're also looking at trickle-down effects. And Prof talked about this. 70% of people don't have access to proper health care. So without having access to proper health care, you're going to have a direct impact on the economy. So these things go hand in hand. So at Biomark, Yoni knows we've been kind of straddling this, and we're very close to introducing this test on early detection. So we were selected exclusively by the largest lung cancer symposium in Germany with AstraZeneca to use our assay to look at the largest clinical trial on lung cancer. It's called the Hanse trial. So the paper was published recently on Lancet. In fact, I was with the team this morning at 5 a.m. and we'll be commencing that study sometime in September. So it's going to be pretty dynamic, and I would love to be able to, share our knowledge, our commercialization capacity, the ability for us to innovate, but more importantly, how do we integrate this into that framework at Tich so that everybody has access to really quality healthcare. So this is just the beginning. I was really elated to see the signing ceremony. My gratitude also to Professor there who was there. I guess Professor Martin Konyango, thank you so much. And we look forward to working with each one of you, because I don't think we at Biomark can be able to provide this infrastructure without your support. So again, I wish you guys a fantastic conference. And if you guys need to speak to me, I'm always available. I look to sharing some of the key learnings that we've had. And, it's really exciting times. So if you have questions, please ask me.
Thank you so much, Dr. Rashid, for that short presentation. I'm looking around in the room. I'm not seeing anyone lifting their hands. But as they are preparing to ask, I just want to say how grateful we are to you and to work with you. As chair of Tich board, we really appreciate the work Prof. Kaseje is doing with the partners just to bring access to proper and quality healthcare in our region. So we appreciate the work. We'll be looking forward to getting the results and also getting the reports from the Secretariat. Is there anyone with a question, a burning question for now? Yes, Yona, you want to add some? Yoni, you want to add something? No, we will not hear you.
All right, yeah, thanks. And my question is just to again acknowledge the great work that you all are doing at Tich, and just looking at the 17th conference. It's not easy to always organize this conference, but I want to appreciate that this has been incredible. I think one of the best association and partnership that we've had over the last couple of months is just knowing about what Prof can do and the enormous value. You might not appreciate what this has, but for us outsiders, we can tell you for sure that Tich is actually produced enormous value of what we do appreciate, and that is how we'll be able to align our collaboration. It's not only a collaboration of impact, but we're also looking at other additional values that we can bring forward to Tich. And Rashid can allude to this. We are lining up investments that can come down to Tich so that we can truly make. And this is my question to Rashid. Please, could you just elaborate as to how much investment and value that we can bring together, Tich working with Biomark? I think that has not come up because he was rushing to go to bed. I know it's late for you, but please, could you just, for the purpose of the audience here, the partners, county government, and all our collaborators in this consortium, could you please tell them how much value that we are trying to look for? We were already looking at, there was already interest for us to work with the Africa Development Bank to fund this initiative, and those were really staggering figures. So I'd let Rashid please go ahead and dive into that question there. Thank you.
Thanks, Yoni. I think part of it is basically utilizing the infrastructure and partnerships that we've been able to mobilize over the years. So we have strong strategic relationship with people like Siemens Healthineers. We've been invited to work with them. We also have important relationship with AstraZeneca Global. They've also kind of showed a lot of interest in what we do. And I think what Yoni was also mentioning is something really important about the ability for us to provide research services for Big Pharma. So this is exactly where Tich can come in and add tremendous amount of value. African Development Bank is obviously very interested in our ability to really demonstrate the feasibility, but we also have other people who could be very interested in what we do. For example, the Canadian government as well. So I do have my marching orders from the Canadian government that we should be looking at enhancing partnership, especially in Africa. And I think this is the perfect timing for us to come and kind of demonstrate that we can do this silently. And part of it is basically making sure we don't have impediments. And, I just learned this, and I can tell you one thing, I've worked in multiple relationships with different organizations, but Professor Kaseji has basically shown me the blueprints of how to make things happen. I wish he could bring that energy to the different enterprises that we have. But sufficient to say is we've had also tremendous amount of success in direct investment from churches in the United States. One of our board members, his name is Alfred Berkeley. He used to be the president at NASDAQ. So he has tremendous amount of reach when it comes to accessing capital. And one of the other things that Yoni always talks about, now is the time. It's a much easier time for us to have access to capital if you have good partnerships and good technology. So I think I can go out there together with Yoni to make people aware of the potential that we have with Tich and the networks that you guys have, because I think every element is being addressed, at Tich and at this conference. So I think the key thing, from my perspective, is this important contribution that each one of us can make, which is basically making sure that we have accessibility to every person in that province and I guess globally. So, that's my passion. I think that's part of the passion at Tich, but also passion shared by many people, at Biomark and the stakeholders that we have.
Thank you again, Dr. Rashid, for the wonderful work you're doing. We look forward to hearing more from you particularly when you go out to the many partners that you have mentioned in your speech. So thank you, and have a good night or good morning. I don't know what time it is.
It's 12:46 in the morning, but I couldn't have missed this for anything in the world, so I really appreciate this.
Thank you again for your sacrifice, and I know we will go to greater heights having Biomech and Tich work together. Thank you again, and have a blessed...
Thank you very much. Thank you very much, and blessings to all of you. Bye-bye.
Bye-bye. Let's clap for Dr. Rashid. Thank you so much, technology team. At least we have heard from him. That would have been terrible if we missed him. That was very, very important. Right now, we want to go into the session. I already introduced the speakers, so we'll go straight to Professor Monica to start us off. Thank you, Professor Monica. If we can do 15 minutes, it will really help us. Karibu-san.
Thank you very much, Madam Chair. Good morning, everyone. Maybe just to introduce myself very briefly. As you've heard, my name is Monica Magadi. Currently based at Keele University in the UK, but originally from Kenya, actually from this part of Kenya, so I'm really pleased to be home, and just want to say a big thank you to Tich for giving us the opportunity to be part of this important meeting. Now, the presentation I'm going to give, which focuses on linkages between health system challenges and digital health interventions. This is going to draw largely from the WHO framework, which classifies various digital health challenges and shows how digital health interventions, and shows how those interventions can be used to address health system challenges. And it provides a fairly good introduction to the program that we are currently working on with Tich, which we are jointly collaborating on, and focuses on how we can use digital health to enhance health systems by trying to see how digitalization can actually improve resilience, particularly during pandemics. Now, just to start, I want to start by just highlighting the WHO definition of digital health, which highlights the importance of digital health in supporting informed decision-making by individuals, the health workforce, and health systems, mainly to strengthen resilience during disease outbreaks, but also overall health outcomes. Now, the WHO has a very useful framework trying to show the linkages between various health challenges and digital health interventions. There are a whole list of challenges which I'm not going to go through, but I just want to highlight the first one, which is around information and aligns very closely with the project that I'm going to provide an overview of in the next part of the session. And also just to highlight how the WHO has, in a way, classified digital health challenges around potential target users, which would include, for instance, what originally they would refer to as clients or patients, health system users, or caregivers. There are also those interventions for healthcare service providers, as we've had during the morning session, which did very well already highlight some of the issues that we are going to focus on today. There are those digital health interventions which are mainly used by health system managers. Again, a very important area, but the project is going to focus particularly on interventions for digital health that is around data services, which focuses on data management use, and data governance. And this links more directly with the information challenge. Maybe just to highlight one example on how the linkage works between the information health challenge and the digital health interventions. Next slide, please. Now, for instance, if we take the case of information challenge, the main, for instance, challenge would be, for instance, lack of access to information and data. Could we move to the next slide, please? And this links mainly to routine health indicator, data collection and data management, visualization. And under the services and application types, we have, for instance, the electronic medical records, which we are going to have a bit of discussion on, both in this session and the afternoon session. Identification registries and directories, as well as the overall health management system. But just to highlight that this is just addressing particularly one aspect of health system challenges around information, which I would like to pay a little bit more attention to, since this is an area that links very closely with the project that we are going to focus this particular session on, and includes, for instance, some of the challenges that health system would need to address would include lack of population denominator, delayed reporting of events, lack of quality data, again, which we'll hear a lot about, communication roadblocks, lack of access to information or data, including data that's already aggregated, insufficient utilization of data and information, and lack of unique identifier, which again links very closely to some of the issues we had earlier in terms of how we can ensure that the data is linked such that we are able to trace, for instance, services received by individual patients in the health system. Now, in terms of classification of digital health interventions around data services, these can be looked at into various broad categories. There are those focusing on data management, where we have areas that include form creation and data acquisition, data storage and aggregation, data synthesis, visualization, automated data analysis. All these are issues that we'll try to see the extent to which we can address in the project. There's also the geospatial information management, which includes managing or mapping location of health facilities or structures, health events, persons and settlements, healthcare providers, as well as health indicator data. There are those around data coding, again, which we'll address in the project, data exchange and interoperability, data governance and compliance. I just wanted to start by highlighting those aspects which are recognized by WHO, which links very closely to the project that I'm going to provide an overview of, since the next set of presentations are going to focus on this particular project, which Tich has kindly dedicated today's session to. So I'll move on to the project itself, that is harnessing routinely collected data for timely healthcare decisions in low and middle income countries amidst pandemics, referred to as the Automate project. Now, this is a collaboration between a number of partners. Tich is taking the lead with Keele University, and also part of the team is University of Sunderland, based in the UK, and working with us, the Ministry of Health, and mainly Kisumu and Siaya counties. The project is jointly led by Professor Margaret Kaseja of Tich and myself from Keele, and key to the project, also taking a big leading role in the project. We have Professor Dan Kaseje, who is our overall, I would say, chief investigator for the project. We have Professor Kelvin Jordan, based at Keele University, who is a lead biostatistician guiding those aspects of the project. We have Professor Yongqiang Chen, who was with us during the launch of the project in December last year. He's a professor in AI and leading those aspects of the project that are around data science and AI. Professor Charles Wafula of Tich and Gluck, who is going to focus mainly on some of areas looking at cost effectiveness, areas in terms of digital health interventions. Dr. Karina Otieno, who is our health information systems kind of expert within the project. And also part of the investigator team, we have Ministry of Health investigators, Dr. Dickens Onyango, taking the lead for Kisumu County, and Kenneth Orwenjo, who is taking the lead for Siaya. Also, co-members of the team include Dr. Tanya Wright, who is the program manager. We have Tich data scientist, Jerosha Otieno, Tich statistician and project coordinator, Beldin Omondi, and Keele biostatistician, whom you'll hear a lot more about in this session and the next session, sharing with us some of the work that is already ongoing, is Kieran Bromley. Now, maybe just to start by giving a very brief background as to what motivated this project. We recognize that health systems, mainly in low and middle income countries, often have limited capacity for timely identification and monitoring of the health, of the potential impact of pandemics. And we recognize that routinely collected data offer great potential for providing timely evidence that is required to inform timely decision making. There is an urgent need, as had been highlighted earlier in the morning session, to bridge the gap between the data and evidence on one hand and policy and programs gap for timely decision making. And this is one area that we think the project has opportunity to be able to see how best to address that particular gap. Now, the WHO, for instance, recognizes the need for healthcare decisions to be informed by timely data, especially during public health emergencies, and states, for instance, that while modifications to data systems may be needed to track the trajectory of the pandemic and its effect on the overall health system, the provision of essential health services should be tracked as far as possible using indicators from existing health information platforms, including routinely collected data or routine health information systems and modeling efforts. So this very much guides the project that we are going to focus on. The main objectives of this particular project, the overall aim is to strengthen health systems in low and middle income countries, starting with Kenya, via digitalization to improve preparedness or responsiveness to future pandemics. And specific objectives include establishing current capacity to use data evidence for healthcare decisions. And we are going to use COVID-19 being the most recent pandemic just for illustration and focusing on maternal, newborn, and child health care and outcomes. We'll use this for illustration just to showcase how data can be used to inform timely healthcare decisions. The second objective is developing digital health and intelligent data analytics tools to facilitate and enhance data access and interpretation and use. And finally, we want to pilot and assess feasibility of digitalization of healthcare systems for timely decisions, mainly to assess preparedness of the Kenyan healthcare system for digital health interventions. The site for the study, mainly Kisumu and Siaya counties, and these two counties were mainly chosen given the strong county government commitment to supporting efforts to improve use of data for decision making and the appreciation of the role of data and information technology in universal health coverage. The project has 3 work streams aligned with the specific objectives. The first one is focusing on establishing current county capacity to use data for healthcare decisions using COVID-19 and maternal, neonatal, and child health for illustration. The second one will focus on developing digital health and intelligent data analytics tools to facilitate data access and interpretation. And finally, the final work stream will be piloting and evaluating feasibility of digital health intervention for timely healthcare decisions. Now, maybe just taking each one of these in a little bit more detail. The first work package, which is focusing on current county capacity. Some of the activities are already ongoing, and you'll have a chance to hear from part of the team in terms of the progress we are making in these areas, and at that point we'll invite your input to enable us make sense of the patterns that we are observing already. This has involved a series of stakeholder engagement and dialogue building activities, as well as undertaking audit of current status to be able to understand how we can work with the current system and see how we can build on that or improve the systems in place. Developing feasible and accurate processes for data extraction and protocol for standard data entry and extraction. Assessment of data quality, again, you'll hear more about that from Kiran. And finally, illustrative example of data analysis to showcase ability of how data can be used to inform policy and practice, where we are using, again, focusing on the impact of COVID, this being the most recent pandemic. Now, the second work stream, which focuses on developing digital health and intelligent data analytics tools, has a broad capacity building component which focuses on improving or training of county data or information system managers or information officers to support the counties in processing and analyzing, as well as interpreting and using routinely collected data in a timely fashion to inform decision making, and co-developing AI-empowered data science tools, which will come mainly during the second year of the project, and developing digital health intervention tools to manage and capture data. And finally, the last work package will mainly focus on assessing feasibility of the digital health interventions in the Kenyan healthcare system. Now, we are hoping that in terms of the overall impact of the project, that the findings will inform the development of appropriate data digitalization and visualization tools in Kenya and other low and middle income countries to enhance evidence-based decision making with feedback loops at all levels. Now, just to finish off by outlining the governance structure of the project, we have an external steering committee which provides high-level strategic guidance and oversight, ensures alignment with broader organizational goals, approves major project milestones, and address high-level security risks. And happy to say that we have representation for that within the team today. Next is the National Technical Advisory Group, which Madam Chair, Elizabeth is part of. We have the project management group, which oversees the day-to-day management of project activities. And finally, dialogue hubs, which facilitate community and collaboration with the counties. I just wanted to finish off with that and say a big thank you for listening. Thank you.
Thank you so much, Professor Monica, for setting the stage. Now we know why we're here. We know what processes have gone on. We know why the study is being conducted in Siaya and Kisumu counties, and we are really looking forward to the impact. More importantly, we also want to hear from you what is going on. Does it make sense? Can we improve it? And so on and so forth. Let's give a better clap. Warm it, warm it, warm it. Warm it, warm it, warm it, and then we give our one thunder one. Warm it, warm it, warm it. Is warming night thunder. Perfect. Now the next one we are going to engage is Dr. Martin Osumba. He's going to speak to us maybe on the general aspects. Monica has gone home to the project. Let's hear from Dr. Martin. Thank you.
Right. Thank you, Liz. And it's my pleasure to join you all in this auspicious conference. It's humbling for me to stand before you to share in this conversation or a number of ways. One, because I don't know why Professor Kaseje believes that I should be speaking, but in his wisdom and the wisdom of the organizers, they thought so. So I humbly accept that. The second thing is because of the entity that's organizing the forum, Tich. From where I come from, Tich means work, as in it's work to get things done, right? But also when you say teach, it means it's young and it's growing, right? So all these things are growing. Before I go into the substance of my presentation, which I believe can be loaded up, I would also want to make a clarification that I have always brought partnerships to teach for places that I have worked in the past. And I recently moved out of RTI and no longer represent RTI, and I want to make that clarification so that anything wrong I say is not attributed to RTI, but more importantly, that everything good that I say is also not attributed to RTI. Right, and so the framing of my conversation with you this morning still is on the background that the question of the role of digital health in facilitating delivery of healthcare is not in question. I think as a people we have moved beyond that debate, right? The second thing is that as a country, as organizations, both government, non-government, we have made great strides in putting digital solutions into our care workflows, all right? And therefore, the essence of establishing those technological interventions and integrating them into service is also not a big question of debate, right? But Prof. Kaseje brought a particular point in his remarks in the morning, and I clutched onto it. He said that what we are doing needs to be measured and we need to count, isn't it? And therefore, the framing of my conversation with you today is extending that point a little further. How do we make sure that we are counting the same thing, right? Because counting is okay, but you could be counting and adding up two different things and assuming that the number you're getting is the number that you ought to be planning for, you ought to be treating, and that has an effect on the health system, all right? And so I will be angling my conversation about how do we integrate standards into our quest for integrating digital health in resolving our health systems challenges. And thanks, Professor Magada, for alluding and pointing us to some of the frameworks that already have addressed the questions of what are these challenges that we are dealing with. All right, next. So the healthcare provider is accountable for a number of things for the patient beyond just getting him or her well, right? The safety of the patient, the security, who gets access to the information, and ensuring that the right people get the information. As a country, I mean, for the last 2 decades, there has been 3 things running concurrently. One, a quick move towards automation and deployment of technology systems, right? And then there's been a move towards ensuring that system to systems can speak, all right? However, the conversations between systems remains a big challenge in our setup. And I'm quick to say that it is not only a big challenge in our setup, it is a global challenge. And there's a global movement in trying to resolve this question. And so let's look into how are we making progress as Kenya, how are we making progress as Siaya, as Kisumu, in making sure that our systems are integratable and are helping us count the same things, right? And that is why I have focused or titled my presentations also advocating for the FHIR standard. Next. But what is that? Sorry, the slide has gone out. So when you talk about FHIR, you need to understand that in the space of health, there are so many things about the care workflow that are standard across jurisdiction. The way Siaya will be running the examination of a patient, preliminary examination of a patient, shouldn't be fundamentally different from where Kisumu is running it, isn't it? And the documentation of such a procedure shouldn't be different, right? They could be somewhat different, but not fundamentally different. And so we know that today there are, if you go to Siaya, probably you'll find a form where the clinician is, documenting the results of that examination. But it's possible that that form is not similar to what you will get in Kisumu. And so FHIR helps us to make sure that there are some resources about care of our patients that are standard and the same across majority of the interventions that any patient will be receiving, all right? And it has been alluded in the discussions we have had this morning, can we standardize how we tell which provider gave the service, which healthcare facility gave the service? Can this integrate into research? Can we tell which devices conducted whichever test that was run, right? And these are fundamental things because, for example, if we are to, make a decision that a device X need to be pulled out of the Kenyan market because of erratic results, on what basis would we make that decision as a country, as an institution, or as a county, all right? Because devices, for example, today are not defaultly reported in our routine reporting for what results they put out, right? And so it is almost impossible to get that data and say, the machine that tests our blood count type X, Y, and Z has been consistently giving us wrong results and therefore needs to be pulled out. However, going forward, it is possible that that should be the space we are able to get to. Rating of our practitioners is something that we need to get to integrate, all right? So that is what FIRE is, and it's, we can go into the depths of it. Because of the problem of not counting the same thing, many of us are aware of the problem, but we are aggravating the problem by going at it our own way, right? So facility A wants to, make sure that they're able to count the same thing with facility B, and so we continuously, figure out how do I make this possible just between me and them, because they are our collaborating partners, right? And therefore we get into this maze where all of us are one way or another collaborating in good intention, with good intentions, but with ineffective ways, all right? That is not going to help us come from the good place we are in right now, where we have good digital systems, we have trained health personnel that can work those systems, but we cannot exchange our data between systems to be able to count the same thing. And so we need to move away from that and ask the question, how do we standardize this process, right? I would want to invite you to understand that as a country we have reached a level where unless we integrate international standards in our digital health systems, sharing of data, counting the same things will continue to be a mirage. And therefore, as we conceive projects now going forward, we need to integrate the thinking of how do we ensure that these systems that we are going to improve, upgrade, are actually helping us measure the same thing. And that's what we are going to look into in a few moments. Standards, as I talk about, are not mysterious. These are things that address some of the questions, or some of the intervention areas that Dr. Magada alluded to, which is identifiers, registries, directories. How do we put them in place? Because when we implement the standards, then we have this super highway that the national government is working on, and we have the Digital Health Agency now in place implementing, that can give us the fundamental structures, fundamental elements, the fundamental infrastructure that is standard across the actors, be it individual actors or organizational actors, or instrumental actors in terms of machines, right? And that is important because as we think about that vision, implementing that vision, then we will progressively be getting data out of our systems that we are certain, without a doubt, that we are actually counting the same things across our jurisdictions, right? It is not uncommon, if we look at a patient journey today, a mother who has delivered at home and has been picked up by a community health worker to potentially be going into PPH and is moving into a health facility. Both the health facility, the healthcare, the community healthcare worker, the family of the patient will be frantic, making what? Phone calls to any and everybody who might have blood, isn't it? Trust me, the receiver of that phone call will most likely not have the information he or she needs to make the decision that will ensure that the response, be it a verbal response or a physical response, actually meets the need of the patient on the ground. Why? Because the question will be, I have a patient, I need blood. Is that enough for you to respond specifically? It's very difficult, right? What's the age, how long, how much, which type, whole blood, all those things come into question, but it is not possible. But that's the reality of where we are at. How do we then transition from there to the technological environment that actually addresses specifically the need of the patient on the ground that has been referred by the community health worker? If you can transition. Yeah, so there has to be an opportunity for bidirectional conversation, right? Beyond this phone call, there needs to be an opportunity for bidirectional conversation between the community health worker, the primary health care worker, and the referring hospital about the specific transaction that needs to happen to secure the life of this mother at risk and potentially the child, right? Next, but that back and forth does not necessarily need to be human to human, right? We need to now move to the realm of computer-to-computer conversation, right? And I'll give you a quick example on how that should work out. It's a quick animated slide deck, and I would beg the person who's driving the slides to go along with me. So imagine this patient has arrived at a physician's clinic, and this information that they need blood needs to be transmitted from wherever they are, raise a request to the receiving entity that is going to receive the request, process the request, and respond back. The challenge there is, we are facing is multiple. One is there are many people we are asking for blood. Are we asking a blood transfusion unit or individuals, right? And therefore, the endpoints for that communication needs to be standardized, right? And the solution for that, responding to some of the WHO identified areas of interventions, is establishing a directory service. The counties, we'll see later in my presentation that the counties play a fundamental role in bringing down to the county level access to existing digital directories, that then systems that you and I will be building or upgrading here are actually reading off standardized directories. Next. Assuming that has happened and you know who you're making the request to, and you're sending that message across to that individual or to that blood transfusion unit, the question is, how do you frame the messaging, the digital messaging that is being shifted across? All right. This is the question where we have to standardize the metadata that you're sending across. That form, the blood transfusion request form for CIA, for example, is it the same as the one that the BTU is expecting to receive? Does it have all the details? We have now technology that should allow us to automate that, all right? And so the exchange and standardizing the exchange and metadata approaches are things that, unless we think about them now, we will remain in the phase that we are in, where we're having digital systems, yes, but they are completely localized and cannot help, support workflows beyond your organization. Yeah, next. Assuming the message has gone across to the receiver, they've received the form, but have they received everything they need to make a decision, right? Yeah. So is the transmission correct? Is it able to validate that they have, the unit you require, the type of blood that the patient requires, that they can verify who is actually, that the requester that is making this request is actually authorized to make that request, right? I mean, these are things that in today's world and as we move towards digitization, we need to be alive to, right? And the challenge there is how then do we measure the conformance of such requests? Today, the requests are happening, they are manually happening on paper forms, and it is hard to really verify, especially when things go wrong, what could be the cause of the error, right? So conformance, the solution there is, as we implement our standards, it will help us to, put in aspects of conformance and certification approaches. And you're able to track which version of a treatment protocol are you following. For example, treatment protocols are updated very regularly, but today it's a book form. If you're unlucky not to have seen the book form, you may not be aware that the protocol has changed. But from a digital point of view, we should be able to, make sure that our systems, our platforms supported by the counties are actually, versioning correctly. And then finally, we get to the aspects of identity, identifying who the persons are, who the requesters are they validated to make the request, are they validated to receive the requests, how should they be responding, and making sure that those identity matches are actually valid. And the next challenge then is, the authority. Today, you have heard that there are people who make money out of selling blood. They know that, situation X will arise, blood will be needed, a request will be raised, and somehow they will have the blood. It will be given, yes, but at a cost, right? So all these things are system issues that digitization should help us. But where we are at right now, if we are to move into the third phase of digitization, unless we adopt standard based interventions in our digital health implementations, we will not make much progress that impacts the outcome of patients, right, and improves the experience of practitioners. And therefore, finally, I think I'm ahead of the person moving the slides. If you can move to slide 17, please. Directories are a must. We cannot do it as individual organizations. We cannot do it as counties alone. There has to be a good interplay between the Ministry of Health, the Digital Health Agency, our county governments, and then all of us who are enthusiasts in technology to make sure that all those directories can be established and maintained. The questions of security is important because once we move into the digital space to facilitate our workflows and to make sure that communication is real time, then the aspects of attack is real, and those issues need to be addressed. Identity. I think identity is something that Kenya has done very well. The regulatory authorities have done very well in maintaining their databases of who the providers are, both organizationally and individually, right? But then mapping that data set to actual encounters of care is really important. And then as we move forward to, like the project that we are going to implement, the question of testing the conformance is really key. So for example, if we are going to look into maternal and child health questions, all right, we should be able to ensure that all the treatment sites that are going to be part of the project are actually recording the same things. So if we are having profiles, that those profiles are standardized, that all those facilities are collecting the same data elements, and that is exchangeable. and we maintain versioning, and that will help us to scale. So I cannot emphasize that more. And so as we adopt these standards, it will help us to integrate, promote standardization. It will help us as a county, for example, to be at the forefront of bringing to life what exists today as the Kenya Data Exchange Regulations. You know, these are already Kenya-based domesticated regulations and specifications on how to exchange data digitally. And, you know, not to forget that it is the basis upon which we will drive innovation through data accessibility, right? And improving consistency on how to accelerate clinical data exchange. So what do we need to do going forward to accelerate this? It would be important as part of, you know, our work, our projects, to produce specifications, data specifications for what we are going to measure, because that then will be integrated into whatever national implementation guides that can be replicated, right? And then we need to update very specific digital artifacts, whether it is the records, whether it is the digital forms, and all. And most importantly is to do the testing and the feedback loop on what we find, not just measuring. So in terms of standards, the counties, the DHA, the Ministry of Health, and institutes such as Tich are important in identifying the relevant standards that will be needed in the use case that, you know, you'll be going into, whether it's project-wise or routine healthcare. The processes will need to be in place to ensure that the artifacts that are developed are able to be tested, and, you know, the declarations that are made on those standardized artifacts can be shareable. And finally, the integration of all the policy and regulatory framework that exists for this country. And Kenya has done a lot of work in defining these things, you know, the Digital Health Act, the Data Protection Act, the County e-health bill that is yet to be passed, the Kenya Data Health Exchange framework, the interoperability assessment. All those are things that will help us to make sense of the progress that we are, the contribution that we are making towards progress. I'm sharing this as a thought-provoking item for us, that if we are to move forward beyond the technologies that we already have, unless we integrate interventions that adopt terminology, messaging, and data exchange standards, we will not be counting the same things, all right? And I want to end by concluding that, you know, what I've shared has been pulled together also by a group of global digital health and informatics experts that are thinking about all these things. And I hope that, you know, we will get challenged as we think about the technologies that we are going to move out from here today to improve, right? And thank you very much.
Thank you, Martin. That has been thought-provoking, just taking us through what is in place, what needs to be done, and what are the practical solutions. The idea of standardization, integration, and so on must be done so that we count the same things. We count the same things, and we are going to do that. So we want to give Martin also a thunder clap, warm, warm, warm. Then you give him one thunder, warm, 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 warm. Angusha. Yes. Thank you, Martin. And we'll be asking you questions regarding those things that you've just talked about. But you've taken us through the process very, very systematically, and we were listening. Thank you. Finally, in this segment, we want to speak about data quality, and we want to welcome our young man from Kiel University. Please give him a clap as he comes. Encourage him until he reaches here. Just clap, clap, clap until he comes.
Good morning, everyone. So I'm Kieran Bromley. I'm from Kiel University in the UK, and I'm a research associate in biostatistics. It's my first time in Kenya, and I would like to thank you all for making me feel very welcomed in your wonderful country. So today I'm going to be talking through health facility data quality assessments. And what do we... can I have my slides up, please? Sorry. Next slide, please. Is that better? Yeah, thank you. Is that okay? Yep. Can I have the next slide, please? So, data quality is essential in healthcare research for generating reliable, valid, and actionable insights. We've got all of this wealth of knowledge and improvements in data and technology and so on, but fundamentally we need to make sure that we've got good, high-quality data to start with to be able to action anything from that data. We want to ensure that data is consistent, and by that I mean that data values agree across data sets, systems, or over time, so we have no contradictions. So, for example, we want to see a child's date of birth is the same in their hospital records as well as their immunisation records, for example. Accuracy, by this I mean that we want data to represent the real world truth, so we want the recorded birth weight matching the actual measured weight of the baby, and completeness, we want to make sure that the required data is present with minimal missing values to be able to have as much power in our analysis moving forward. Timeliness of data is also fundamental to high quality research, and this is making sure that data is current and accessible to at the time that it needs to be used. And by having high quality data, this allows for us to have to implement changes in practice and policy, and then also improvements in healthcare outcomes at both the individual and the community level. So my general aims are going to be to assess the quality of some of the data collected across multiple sources, and to ascertain the usability of the data for future analysis. So Monica introduced the Automate project. So I've recently become a member of the team working on this, so this is all very much new to me, and I'm still getting up to speed with the project. So this is all very early findings, and similarly will be the same for the illustrative analysis that I'm talking about at the end of this session. So, as I say, data collection needs to be reliable, rigorous, and done in an accurate manner. It needs to be as complete as possible to make sure we have as much data to analyse, to make inferences from, and it needs to be consistent and recorded in standardised formats. And also clean. We need data to be usable and understandable. And I can reiterate and say towards the end there. So the data that I will be talking about, the focus was mainly on 3 different sources. So we were looking at maternity data, antenatal care data, ANC data, and also we were going to focus on immunisation data, but given time constraints within the project, we are pausing that for the moment. The data we have is collected across both counties, where we have 6 sub-counties in Kisumu and 3 sub-counties in Saia. And the data is sourced across multiple levels, through dispensaries all the way through to the county referral hospital. And at the moment, I have had access to some preliminary maternity data, which contains 30 different outcomes. So there will be updates to this data, so the findings today aren't finalised, and also there'll be more data to look at in the future. I would just like to note here all of the hard work that's been carried out by the data clerks at this point, and also partners at Tich in getting the data ready to begin with. It's been a huge undertaking. So moving on to data consistency. So consistency across counties and sub-counties is what we need. We need to be able to say in every different place that data has been recorded in a standardised format. Examples of this is that we want date formats in the same file and across sub-counties and counties to be the same. So, for example, in the same data set, we would have date of admission and year of birth, and we would want these to both be in a usable format so that we can use that for analysis. So, for example, if we have a missing age of a participant, a patient, we can then calculate it from there. Similarly, we need time variables to be recorded correctly. So looking at some of the data so far, there's been cases of just hours being recorded, or I'm not sure if data is in 12 or 24-hour format. So it's about having this consistency of standardization in the way that data is recorded. And then we also want consistent recordings of outcomes as well. So we want to ensure that when data is being entered into systems, we're either using labels or codes consistently throughout, and not a combination of the two. So, for example, we may say that a birth is, if they're underneath 2,500 grams, so they're a low birth weight child, we may say that they are LBW for low birth weight, or we might also use one, which signifies, yes, they are low birth weight, but we could have a combination of both, and we want to make sure that data is consistent and uses one or the other. And as I say at the bottom there, antenatal data is coming soon, and the consistency will also be checked there as well. So moving on to data formats on the next slide. So we have different types of data. We have continuous outcomes, so we need these to be stored as numeric data, so we want only to contain numbers, so we have data collected in the right formats. Some people may know how hard it is to deal with string variables in different statistical packages. And some of the examples of this has been with the date of birth and age data. Rather than reporting 32 years, we're seeing 32 years written as YRS at the end. So these aren't quite suitable and require additional cleaning to make the data usable. And also there needs to be checks that are carried out on this data to ensure that it falls within expected ranges for that data. So we wouldn't want to see a mother of 250 years being entered within our data. Similarly, we want to make sure that categorical outcomes are formatted correctly. So we want to make sure that we're using the expected categorization that we would expect to see. So male and female. If we are using male and female, we might just use M and F, so we would only want to see that. So we wouldn't want to see a combination of all of those, or also potential categories that don't make any sense to that outcome. But also we might have special cases of data. So we have parity data that's collected, and this has been recorded as X plus Y. So we have, this is a different case that needs handling slightly differently as well. And from a statistician's perspective, having data in the correct format makes analysis much easier. Now, as I've mentioned a few times, we want to make sure we have enough data as possible. It's all good and well trying to collect data on participants and carry out sophisticated modeling and statistical analysis, but by having gaps in the data throughout data, we lose the ability to model all of that data, and we lose what we call power in the analysis. And we want to have as much power as possible to be able to provide high quality insights that then better inform decision making moving forward. And for every missing data point we have, we potentially lose someone from our analysis. So we have data that's been entered as either MD or NIR, so missing data or not in record in most cases. And I've got on the next slide just a brief look at some of the completeness of some of the outcomes. So here we have, just for some of the variables, just some of the completeness of data. So the first one is admission date. So we have, in the data that I've been looking at so far, we have 52,312 rows of data. So these are all maternal data in the maternity data set, so that's 100% of data. We know the admission date for all of those. However, we can then see from there, so if we use that 52,312 as our denominator, we see that actually our admission number that the person was given upon entry, or that they already had, is actually missing in 2.9% of cases, which doesn't sound like a lot, but these are variables that are going to be important moving forward if you're trying to have an identifier for a person that you want to then match across different sources, or have a singular identifier across all points of entry of data. We can see that there are ranges of different variables being missing. I think gravity or delivery date are the lowest. So given this is maternity data, we have delivery date only complete in 74.7% of cases. So for over 10,000 births, we don't actually know what date the child was delivered. So, you know, there's a big gap in data there. We have multiple birth outcomes that are collected. So first birth, second birth, third birth, and so on. And so I'll just read from this for a second. So for looking at just the first birth outcomes that are recorded, we have 87.4% of the outcome of the birth recorded, so whether it was a live birth or not. But strangely, we have more weights of the babies registered, so we have 88.2%. So although we don't know the outcome of the child's birth, we actually know the weight for some of them as well, which doesn't quite make sense. And then we only have sex for 87.1% of babies as well. So there are gaps in the data, and at least with these outcomes for the babies, they do correspond within the row, so it's not like it's staggered throughout. But these are important variables that we want to know about these babies, what was happening at the point of delivery and so on. And you know, when it comes down to 87% of data, we're losing over 6,000 entries. And on the previous slide, I've just got a graphic just to show that data completeness. So I've mentioned data cleaning as well. So what do I mean by this? So we're ensuring that data is in a usable format. That's great, but where it is not, can the data be cleaned to become useful? So I've had a good look in particular at the date of birth and age variable that we've had. So this variable is a combination of both date of birth and age in a single variable. So we have either the date of birth or age of the person, and what I tried to do was categorize the formats of the data that we received. So we had a numeric age for the person that could be calculated in 84.4% of cases, so in 44,000 cases. We had a textual age, so this is where it was written out, for example, 32 years, in 8.3% of cases. We had past dates in 4.7% of cases, where it was the actual written out date itself that could then be used with admission date to calculate an age. In some cases, in 0.8% of cases, we only had the year of birth, so we don't know the exact month or day of the month. So then if we're trying to calculate an age from that, we have to make assumptions about their age there. And then we also had year with a suffix, where we would have the year plus a month as well. So it's a bit more data than just year only, but it's still not ideal. And then of the 52,000, there was 306, 0.6% that I couldn't categorize into one of those groups. It was a well-completed variable. We only missed out on 252 data points. And of those 252, I was able to go through and do manual checks to include another 191 of those. So by carrying out data cleaning, we can see that we've jumped from 84.4% of available data up to 99.3% of data, when there was only 99.5% of data available for age to begin with. So by using data cleaning processes, we can really maximize the data that we are receiving when it doesn't come in a standardized format that we expected to begin with. So finally, I'm just going to talk about some good practices and some next steps. So the first thing is data validation. We want to make sure that data meets predefined rules and criteria, and we also want to ensure that we've got accuracy and suitability of the data for analysis. And how do we validate our data? So we want to do our formatting checks. You know, all dates are in day, month, year formats, for example. We do range checks. We check the ages fall between a suitable range, say 14 to maybe 100, 120 years. And that's not to say that values wouldn't be accepted outside of those, but we would want to do a manual check on those to see whether they make sense. We want to do coding checks. As I alluded to, we want to make sure that there's consistent method of labeling and coding to ensure that all variables conform to the derived codes that we prescribed to begin with. Consistency of measurement. So we want ages to correspond with the date of birth. We want to make sure that the birth weight of a child is entered in grams or kilograms and not a combination of the two. We want to make sure that it is in metric, not imperial as well, for example. And then we also would want to do cross-field validation as well. So we want to check, for example, that the discharge date in our maternity data precedes the admission date, because otherwise that wouldn't make sense. So we want to make sure that the data is accurate as well. And then a final recommendation is to regularly audit data to identify emerging data quality issues. So finally, what are the next steps? Well, there's a lot more work to come. This is very early in the process. There's going to be a deeper dive into the maternity data and also the ANC data. This will include complete descriptive statistics for all outcomes, so producing extensive tables of statistical measures, including means, median, standard deviations, ranges, and quartile ranges. We're doing Z-score analysis to identify potential outliers from the data where they lie too far away from the mean. Visualizations for looking at data completeness, spread of data, and also over time monitoring changes in data to identify potential abnormalities in recording or in the data itself. And also looking at comparisons with historical data, so we've got aggregate data that we are going to use as well to compare to, and checking data uniqueness. We're going to carry out some data linkage using probabilistic data linkage methods, which I'm not going to go into too much detail about now, but we're going to try and link the maternity and antenatal care data for now, because that's the data we're going to get our hands on. And then we're going to carry out some more sophisticated analysis of the individual level data. So trying to determine the impact of COVID-19 on individual level outcomes through multi-level and causal mediation modeling. Thank you very much.
Thank you so much, Kiran, for your presentation. You've taken us through what constitutes data quality, what is happening on the ground, what are the good practices, and where do we go from here. Let's give him also another thunder clap. Let's warm it, let's warm it, let's warm it, let's warm it, drop it. Thank you so much. So we have heard from our three powerful presenters. Monica started by telling us the background of the project. Dr. Sumba took us through some good practices. And then Kiran has spoken about data quality. I want to open up this in the next 6 minutes, maybe to get very hot questions, burning questions, 6 minutes, so that 12 we can go to the next session. The floor is open. Shall we have the roaming mics in case there's someone? Could we have those who want to ask questions? Your hands up. Yes, there's a hand up from Reverend Thomas. Yes.
Thank you, Madam Chair, and thank you, very dear colleagues, for those presentations. To all of you, actually, from your presentations, it's digital health systems efficiency. Would you be envisioning a situation where the health system will go paperless? Is that where you're heading to? Or what are your strategic objectives going forward? Mm-hmm. Is it a paperless health system we are looking at?
Mm-hmm. Who wants to take that? I'll start with Monica and then give it to Dr. Martin.
Thank you very much for that important question. I think the project we are trying to work on is precisely trying to establish whether that is one of the things that the Kenyan healthcare system is ready for, whether it's possible for us to go paperless. But based on what we've come across already, because there are a whole range of challenges, whether it's to do with the infrastructure, whether to do with availability of a working computer system that we can enable us maintain some of the practices that we know are ideal, but whether the Kenyan healthcare system is ready for that is something that we are trying to establish. So in the final work package, which will be for piloting and assessing feasibility of digitalization, we are hoping at the end of it we'll be able to answer your question. But at this point, it's one of those things that we are trying to see the extent to which the Kenyan healthcare system is ready for. Thank you.
So we tried to go paperless, particularly where I was before, but we realized that there are many challenges, like Monica said, in the field. So we started e-learning, and then the internet, and then the power, and then the blah, blah, and you know. So we had to bring in the blended learning, and it worked. And it really helped us during COVID. Martin, you want to add?
Okay, I'm here already. Yeah, I mean, paperless is a buzzword. It's great going paperless because we think, there's the benefits of everything, right? But I would look at it more of we want to make the system not paper constrained, right? Or paper dependent, such that, because we are using the paper, we cannot deliver efficiently, we cannot deliver safely, right? So the bottom line is, if we go the direction of adopting standards and conformancy, and we are leveraging, maximizing on the investments on technology that we are making, right? We will be getting greater outcomes, right? We'll reduce certainly our paper, but will not necessarily obliterate use of paper, but paper will not make our systems inefficient. Yeah. But if we can go 100% paperless, great. I mean, Thailand International Hospital is completely paperless, but they still integrate with the other facilities around them.
Thanks, Martin. There are two more questions. Let's take both of them. We start from the back, and then we come. It is off.
All right, thank you. On the question of going paperless, I'll tell you a testimony I had during the 2016-2015 Ebola outbreak in West Africa. And Ebola was highly contagious. Everyone had to sanitize anything that you touch. So when you touch a patient and you do a paperwork, you had to spray the paper so that it's not contaminating the next person. So look at how much data was being lost when you sterilize a paper with either ethanol or chlorine. 10 years later on, today, we've not yet gone digital, but we know very well from whatever data I presented over there at the clinic is, if we can have it digital, then we can minimize the data disparities or the data omission or data elimination that come with transfer of data. I think from what I see is that most of our data is lost due to transfer from paper to any other format. And that takes me to the next question. I know Kenya Health Information System, the DHSH, the District Health Information System, is a system that we only use locally here. This was a World Bank project that was initiated years back, and it is adopted across almost all African countries. In Kenya, we call it Kenya Health Information System. I think it captures a bit of some demographics, but does not capture everything that can inform beyond maybe policy and framework. It cannot inform anything, research or anything on that. I stand to be guided. I don't work around it, but look at that was being adopted across Africa because it was a WHO initiative. But now we leave that alone and then look at EHR systems, like whatever he described there as the information system that they use to capture data. Every developer tried to develop his own system to capture his own variables. And if I'm developing a system or a health EHR system, and my good friend Prof is developing something, we will all capture different elements of those data. That again will take us to the process of disparity. So harmonizing data is a problem because you have a developer like me and 10 other people here giving us different segments of data that when we want to harmonize this data to communicate something, then we have things that are, like we saw in all those presented, things that are missing. But then what do? We are in the age of AI. AI is a protocol that has been developed, and any other person can work around that protocol to develop something because already the guardrails have already been made. So when I'm inside there, I'm not doing anything outside of what the AI provides. Think of it like the IT protocols that form the internet. You can only communicate with it as an internet. There is no any other thing that you can use for it. So I think in healthcare, it has been 70 years of things that have always been functioning differently. I don't know how we're going to correct all those things together so that we have protocols that actually point to the same things, such that when we collect data, we all collect the same information. So thank you for that, but they can respond.
Thank you. Maybe we give it to DMS Kisumu. What is hands up? DMS Kisumu. Just make it short, and of course the boss, my boss from CII is also here, but give it to the DMS Kisumu first.
Thank you so much for the presentation. I have a comment and a question. The first presentation on the project that was presented by Prof. It was a very huge project, and my comment is that most of our learners or those who are in research, you find that most of them delay in their thesis presentation and writing. And I want to comment that this can be a platform for those who are doing their PhDs to anchor on your project so that they can complete their PhD. In Kenya here, the problem is the project, not people attending the classes. And you find that in a university with 100 students or 100 learners who are doing their PhDs, only 1 or 2 manage to graduate because of the thesis and the project. This could be an open space for those in Luke and also at Tich to help them find a way of how to graduate. Speaking because when I was doing my MEd, my lecturer, Professor Ndwati, told me, I'm just teaching you how to do research. Just anchor on me. And I'm telling you, I cleared in the record time because of our help. So that project that I listened to will be a very good fundamental basis for those who are doing their PhDs. The comment on digitization, Kenya is ready to have paperless. Kisumu, as we speak, we are at 45%. Paperless, you walk in a facility and come out without any paper. The nearest from where we are is called Railway Health Center, Wellness and Health Center, somewhere 1 kilometer from where we are.
that can be a platform and a testament that the government, through the superhighway, is ready. And as Kisumu, where now I'm speaking on behalf of the governor and the deputy that I'm presenting this meeting, this conference, the Department of Health is ready to go full paperless in a period of 2 months. The Taifa Care had been launched in Kisumu by the CS, Duale, and we are doing a lot behind the scene. And the Division of Digital Health, currently they are in Naivasha today, this week, doing a lot of training and a lot of capacity building to make this paperless a reality in Kisumu County. Thank you.
Thank you so much. Congratulations to Kisumu. CIM, make it short.
Oh, thank you. Thank you. Do I call you Professor Elizabeth?
No.
Yeah.
Just Elizabeth.
Okay.
They call me that, but not yet.
Okay. Let me start by thanking all the 3 presenters for wonderful presentations. We really appreciate. These things take a lot of time and energy. Mine, just like directors put here, is also more of a comment. I'll make it very brief. It might lean towards lamentation, but don't name me Mr. Lamenta or lamentation. Mine is just to take you back to what Professor Magadi presented, the first slide. I think the first slide was to do with information and interventions. And Prof, you have highlighted the issues of the challenges. My comment and lamentation is that the challenges which we know, and these are to do with the availability, network connectivity, electricity, the staffing, capacity building, equipment, sustainability. These main issues, very critical, are so important that for us to move forward well and get data digitalization and utilization for improved livelihoods, it would have been better to handle those challenges and streamline them and put them in a working perspective before we go to the next step. What Dr. was highlighting in the second presentation, and even what was highlighted by Kirian, yes, all these are because different counties cannot handle those challenges, and it will make work very difficult because the basics are not in place, and it's rather unfortunate that time is not waiting for us. We have to move forward, gather the data, go paperless, and Turkana is probably way behind. I've worked in institutions where once the basics are all put in place, you really move together very fast, very seamlessly. So I'm not just lamenting that we don't have electricity, or the equipments are not there, or there is no staff to handle them. But I'm trying to say that the way we are moving haphazardly, some counties ahead of others, will give us perpetual challenges and problems, because the diseases that we are trying to put together and analyze and improve livelihoods do not have boundaries. And I feel that, I know a lot of work is happening on this. As we sit here, Siaya is the biggest beneficiary with the developments that we just signed an MOU for Seradidi. But we really need to move together. So I think whatever efforts we have on those challenges that are facing us should be unified efforts and concerted and focused and sustained, and we all get, at the end of the day, you will tell me it's the exchequer and it's the funding and it's our poverty and it's all this and that. We just keep on lamenting. I want to stop there.
Thank you so much, Honourable Minister, for those very good comments. I want to, and everyone else for the comments. I want to give each presenter half a minute, just to give the parting shot and maybe respond to this in half a minute. Thank you, Martin. Then we pass it on.
No, thank you, Liz. No, I just want to agree, first of all, with CC. All these things must happen in tandem, you know, while we figure out the technological imperatives to move forward, the infrastructure aspects, the human resource aspects, the, you know, national shared infrastructure also need to be upgraded. And I think that's the basis upon which congamanos like these ones should resolve on how best do we bring entities that share an interest together. LRED, for example, you know, should be having a conversations around how to attack digital health integration in unison. Which aspects of infrastructure will they share or commonly attack versus having, you know, fragmented interventions. So I agree with you in entirety. And finally, the parting shot for me is what Otieno mentioned. When you look at the fire standard, it's actually, you know, learnings from the internet. Today, if your child asks you a question that you don't have an answer to, where is the first place we go?
Dr. Google.
Google, isn't it? Yeah. And so the protocols upon which, you know, the webs, the universe of the web has been designed is the basis upon which the health fire standard has been developed. And so I think we are in tandem. It's making things discoverable. It is making things unique. Yeah.
First thought was that yes, it's great that there's the capacity moving forward to move to a paperless system, and there's so many advantages to that, you know, data quality, adherence, and so on, that then helps promote policy informing and so on moving forward. But you've also got the issue that you're leaving data behind that's already been collected by paper methods and different methods and so on, and we need a lot of that to then know about what's happening in the future, to understand what's carrying, you know, what is going to continue to happen and so on. So we need to learn from that old data, and that is where, you know, a big problem is still going to lie, is taking that data that's been collected in different formats and, you know, paper and stored in different places, different formats, and putting it all together in a singular data flow and databases that can then be used to then, you know, inform policy and analysis and so on. But I think it's great that the possibility of moving to paperless is great, and there's going to be other problems with that as well at the same time. But maybe, you know, it's not the worst problem to have, that you've got this capacity to be able to move forward. So yeah.
Thank you very much. I'll try to be very brief. First of all, just to say, really encouraged with the level of digitalization that's already ongoing, particularly in Kisumu County. And in this project, we are going to try to see how best we can build on that, or areas that we can make some contribution to strengthen the system. In terms of the issue raised for opportunities for PhD training that the project could contribute to, this is a 3-year project, and we did consider that, but realized that maybe that might not be possible. But since at the end of this we have a pilot, we are hoping that if there are indications that there is a real chance of digitalization system working well, that will move on to a fuller scale evaluation that then will open those kind of opportunities for PhD training to be linked to the project as well. Again, just to recognize some of the challenges that have been addressed. I think as the project, we may not be able to directly address those, but we are hoping we can raise some of the issues that maybe might lead to recognition of some of these challenges and trying to ensure maybe in terms of resource allocation, this prioritization to some of these that then make the system work more efficiently. And finally, just on the first point raised in terms of the numerous digital health platforms that exist, we did precisely come across that when trying to develop the project. And that's one reason we established that for this to be able to make a difference, we needed to partner very closely with the Ministry of Health, so that what we are going to do is not coming up with new systems, but trying to see how best we can work with the system that's already there, but trying to see how best we can improve that or strengthen the system. Thank you very much.
Thank you again, the presenters. I think we'll end it there because time is well spent, but they are here for the next 3 days and you'll be listening to them. Yes, I know Margaret is campaigning, but we'll go on. Let's just give them the final round of applause to our presenters as they go down. 1, 2, 3. This one is now the Nyayo one. 1, 2, 3. Ding, ding, ding. Ile. Ya Nyayo. 1, 2, 3. 1, 2. Gisanja. That's it. So we'll allow them to go down as I bring on board 4 wonderful presenters. Kwa ground vitu ni different. On the ground, there are many things that are happening. We want to listen to someone from Alego Usonga, Benjamin Bala. We want to listen from Maureen Nyanja from Ugenya. They should be walking as I speak. Kiprono Priska from Nyakach, and Lucia Tandi from Game. They are all 3 ladies and 1 gentleman. We'll give them 10 minutes each to speak to us from the ground. Okay, so we have Benjamin Bala. Are you in the house? From Alego Usonga? Represented. Okay. Maureen from Ugenya? Ugunja. Oh, yes. Maureen. Then we have, is also represented, Kiprono Priska from Nyakach. You are there? Okay. And then Lucy Atandi from Game. You are there. Thank you. Just confirming that the technical team have their presentations. Yes, perfect. So we'll start with Benjamin Bala's representative from Alego Usonga, just to tell us what's going on the ground. And like we said, we'll have them back to back, 10 minutes each, and we see where we reach. Then we have Kiran to come back again to speak about the early findings. The early findings. So we have, please introduce yourself in half a second, and then you can do the presentation.
Okay, thank you very much. Good morning, ladies and gentlemen. I'm Mercy Korwa. I'm a HRIO, Alego Usonga Sub-County, Siaya County. With me here, we have a paper from Alego Usonga Sub-County. The title is Trends in Maternity Service Utilization by Aggregate Data in Alego Usonga Sub-County, Siaya County. The authors are Benjamin Bala, Korwa Mercy, Muyoyo Dolphin, Orwenjo Kelvin, Otieno James, Nakungu Betty, Ouma Lois, Olwando Elvin, Onwonga Violet, and Gombe Viviana. So on the introduction, maternal health care utilization is a critical aspect of reproductive health, playing a vital role in reducing maternal mortality and morbidity. Despite the effort to improve access to maternal health care services, many women, especially in low and middle income countries, continue to face significant barriers in utilizing these services. Studies have shown that factors such as social economic status, education, and distance to healthcare facilities influence maternal healthcare utilization. According to World Health Organization, approximately 94% of all maternal deaths occur in low and middle income countries, highlighting the need for sustainable and scalable solutions to mitigate adverse maternal health outcomes. In 2023, globally, about 260,000 women died during the following pregnancy and childbirth in 2023, with 92% of these deaths occurring in low and lower middle income countries. This study, therefore, aims to explore the trends in maternity service utilization among women in Alego Usonga Sub-County between 2018 and 2024. By examining these trends, the research seeks to identify patterns, challenges, and opportunities for improvement in maternal health care delivery. The findings of this study will inform policy and programmatic interventions to enhance maternal health outcomes in the region, contributing to broader goal of reducing maternal mortality and morbidity in general. The research question that is guiding this study: what are the trends in maternity service utilization among women in Alego Usonga Sub-County between 2018 and 2024? This question will help us uncover the dynamics of maternity care utilization over time, shedding light on factors that influence healthcare seeking behavior and service delivery in this specific context. Our problem statement: the utilization of maternity service in Siaya County in Kenya remains a significant concern due to high maternal mortality rates. Despite effort to improve healthcare, many women in Siaya County face barriers in accessing essential maternity care, including ANC, skilled deliveries, and PNC. This underutilization poses substantial risk to the health and well-being of women and their newborn. This research has not been done by anyone. Therefore, this study aims to provide insights into maternal healthcare utilization trends and patterns, informing evidence-based intervention to improve maternal health outcomes in the sub-county. General research question: what are the trends in maternity service utilization among women in Alego Usonga County between 2018 and 2024? Our specific research questions: what is the facility delivery trend in Alego Usonga between 2018 to 2024? What is the trend of baby outcomes in Alego Usonga between 2018 to 2024? What is the trend of mother delivery outcomes in Alego Usonga between 2018 to 2024? The methodology of this study, our study design, this study employed a retrospective analysis of existing data from the KHIS. The period was between 2018 to 2024. Our study population, we carried this study in Alego Usonga sub-county from various health facilities from level 2 to level 5. Data collection, the study utilized secondary data from the KHIS. The study period 2018 to 2024. Data analysis, we did a descriptive statistics. Frequencies, percentages, and trends were calculated using Excel to summarize the data and describe patterns in maternal service utilization. Data visualization, Excel was used to create charts and graphs to visualize trends and patterns in the data. There we have the results. Skill deliveries from 2018 to 2024, a total of 42,405 skill deliveries. We have the status of the baby outcome, total stillbirths of 1,135 from 2018 to 2024, live births, a total of 41,270 from 2018 to 2024 across level 2 to level 5. Status of the mother delivery outcome, we have mothers alive, a total of 42,375, and status of the mother dead, we have 30 mothers from the period of 2018 to 2024 across level 2 to level 5. Baby discharge, we have a total of 40,924 babies discharged between 2018 to 2024 across level 2 to level 5. The above results is shown in the line graph. The first line graph, we have the delivery trends, you can see from 2018. The second one, we have the trends of baby outcomes in bar graph, 2018 to 2024. Then we have the trends of mother outcome, 2018 to 2024. So on our discussion, delivery overall trends, facility deliveries rose from 5,418 in 2018 to 5,916 in 2019. There was a dip in 2019-2020, which is consistent with other studies. In 2020, there was a decrease in health facility deliveries, which may have been due to COVID-19 intervention. There is a reversal from 2023 to 2024. Deliveries dropped to 6,059, signaling possible barriers like economic hardship, service quality concern, or external shocks, such as climate events, disease outbreaks. We have birth outcomes and stillbirths versus live births. Stillbirths improved from 36.7 per 1,000 in 2019 to 21.5 per 1,000 in 2022, but worsened to 24.1 per 1,000 in 2024. Live births mirrored delivery trends, peaking in 2022 and declining in 2024. In 2024, we had an anomaly where stillbirths increased despite fewer deliveries, suggesting quality of care deterioration. Maternal mortality, we had 0 deaths between 2018 and 2019, which portrays an initial success in maternal survival. There was alarming rise in 2020 to 2024, where in 2020, we had 4 deaths, maternal mortality ratio of 71.7 per 1,000 live births. 2024, we had 8 deaths, maternal mortality ratio of 135.3 per 100,000 live births. This may relate to the healthcare worker strikes. Exclusive general comments, these maternal deaths were generally from the level 5 facilities, which indicates these centers handle high-risk cases but may lack resources such as staffing, equipment, blood banks for emergency services. Baby discharge trends, we had high efficiency, 2018 to 2023, 99 to 100% discharge rates. 2024, we had a collapse of 95.7, implying maybe increased neonatal complication and deaths, and policy changes like longer stays for high-risk infants. On the delivery, facility level utilization disparities on delivery service, level 5 dominated on the delivery share. They handled 60 to 66% of deliveries, indicating over-reliance on tertiary facilities. Lower level underutilization, level 4 had stable but lower share, 19 to 24%. Level 3 declined from 19 in 2018 to 15% in 2024. Level 2, they had a minimum roll of less than or equals to 1.5. So the implication of this, there was a weak referral system and capacity gaps at primary levels. The recommendations, we have urgent and strategic actions, immediate priorities by the sub-county, maternal deaths audits. We have to conduct root cause analysis of all 2018 to 2024 maternal deaths, focus on level 5 facilities, review emergency obstetric care protocols, staffing and commodity availability. 2024 anomaly investigation, assess service disruptions such as strikes, drugs shortages, infrastructure damage. Number 3, emergency response, deploy mobile clinics to underserved areas, that is level 2 and 3, stock essential supplies. Then the medium-term strategies for referral system strengthening, we have to continue training level 3 and 4 staffs in basic emergency obstetric care, implement telemedicine for real-time specialist support from level 5. Then we do facilitate capacity building. Then we do community re-engagement, whereby we will be able to address 2024 utilization drop via community dialogues on service quality. Long-term systemic solution, we'll have to check on the health infrastructure investment, whereby as a sub-county we have to upgrade level 3 and level 4 facilities with labor wards and basic labs, establish a functional blood banks at level 5. We have to enhance data system overhaul, digitize maternity records to reduce errors, integrate facility and community data for real-time monitoring. Then policy advocacy, push for increased county budget allocation to maternal health. Our conclusion, the maternity service utilization trends in Alego Usonga sub-county reveal a bifurcated narrative, whereby initial progress in increasing facility-based delivery in 2018 to 2024 was overshadowed by maternal mortality crisis and systemic failures emerging from 2020 onwards. While the sub-county achieved milestone in expanding access and reducing stillbirths, these gains are now fragile due to maternal survival collapse, system breakdown, structural inequalities. Our path forward, therefore, is a sub-county. We agree that without urgent intervention, Alego Usonga risks reversing a decade of progress. Therefore, success requires immediate life-saving actions, medium-term system fixes, long-term investments. The data underscores that access alone is insufficient. Quality care, emergency responsiveness, and equitable resources distribution must become the cornerstone of maternity services in Alego Usonga sub-county, so as to be able to cap the rising maternal mortality in the sub-county. As we all agree that maternal mortality is not merely a statistic, it is a call to transform health systems before more lives are lost. Limitations, the study's limitations include potential data quality issues and incomplete reporting. Thank you very much.
Thank you so much, Alego Usonga. That's excellent. Excellent presentation. But the figures are worrying, and Honorable Minister, you are here. We, in other counties, are celebrating 0 deaths. zero maternal deaths. And we are going to discuss this seriously, what can be done to limit this. But otherwise, I'm celebrating. I'm celebrating because people are already using the project Dr. Monica spoke about and Prof. Kaseje to make sense of the data, analyze it, and present something like this. A clap for them even before the others come. Thank you. So we move to Ugunja. Let's move to Ugunja. Maureen.
All protocols observed. Good afternoon. My name is Maureen Adero, going to present Ugunja Sub-County. We are presenting a paper on maternity service utilization trends in Ugunja Sub-County, period 2018 to 2024. Maternal health services refers to health of women during pregnancy, childbirth, and the postnatal period, according to WHO 2025. Maternal service utilization trends indicate an overall increase in the use of maternal health services, including antenatal care, skilled birth attendants, and postnatal care. This rise is often linked to policy initiatives such as free maternity care, improved healthcare access, socio-economic improvements, and heightened maternity health awareness. Globally, 90% of women utilize skilled antenatal care at least once, but only 57% complete the recommended 4 or more visits. In Africa, these figures are 53% and 49% respectively, with the recommended number of NC visits being at least 8 for women in developing countries, according to Twagirumukazi et al. 2024. Our introduction. In sub-Sahara Africa, skilled birth attendance is relatively high at 78.8%, but NC and postnatal engagement remains suboptimal at 55.2% and 40% respectively. Socio-economic factors and women's autonomy influence utilization patterns, with regional disparities observed. Effective interventions include removing financial barriers, integrating traditional birth attendants into formal systems, improving facility access, and increasing public health awareness. Ahinkora et al. 2022. In Kenya, facility-based births increased from 44% in 2008 to 61% in 2014, partly due to removal of user fee of childbirth. Free maternal health policies have notably boosted service utilization, although geographic and systemic challenges remain, particularly in Siaya County, where maternal and child health indicators lag behind national averages. Odhiambo et al. 2019. Our general research question: what are the maternal service utilization trends in Ugunja Sub-County during the period 2018 to 2024? General objective is to analyze maternity service utilization trends in Ugunja Sub-County from 2018 to 2024. Specific objectives: to examine patterns in facility-based deliveries, to evaluate birth outcomes, including live births and stillbirths, and to analyze discharge trends among mothers. Study design was retrospective descriptive study using quantitative data from KHIS. Study area, Ugunja Sub-County, Siaya County in Kenya. Study period 2018 to December 2024. Methodology, Kenya Health Management Information System. Population, all women who access maternity services in public health facilities within Ugunja Sub-County during the study period. Data collection, we had extraction of indicators, that is deliveries, birth outcomes, and discharges. And we also had structured data abstraction tools for consistency. Data analysis, we use descriptive statistics geographical representation of trends, and comparative analysis across years for patterns and anomalies. Ethical considerations, approval from relevant authorities and ethics committee, and data anonymization to protect patient confidentiality. We start with the trend in facility deliveries 2018 to 2024. This was the trend from Ugunja sub-county. In 2018, we had 1,940 deliveries, which improved in 2019 to 2,155. In 2020, 2,080. And then we had a drop in 2021, 2,034. And then we concluded with 2,363 deliveries in 2024. Under deliveries, our findings, total deliveries we did were 14,883 over 7 years. The facility contribution, we have level 4 having the highest at 74%, level 3 had 26, and level 2 facilities, which are dispensaries, had only 89 deliveries, which is 1% from 2018 to 2024. The trends, overall deliveries increased in 2024, recovering after fluctuations in 2020 to 2021. Highest year-on growth in 2019, that is plus 11%. Then level 4 facilities are the main providers, and overall delivery numbers show a stable upward trend. Under baby outcome trends and stillbirths, that is live births and stillbirths in 2018 to 2024. In 2018, we had 1,907 deliveries, 31 stillbirths. In 2020, we had 32 stillbirths, 2,020 deliveries. In 2024, we had 49 stillbirths and 2,342 deliveries. That is baby outcomes, live babies, not deliveries, live births. I'm sorry. Stillbirth rate trends from 2018 to 2024, that is trend in rate in percentage. In 2018, we had 1.6%. In 2020, 1.7. 2021, there is a decrease to 1.6. 2022, 1.5. Then a sharp rise in 2024, 2.1%. That is stillbirth rate. Baby outcome results, we had live births, that is 14,561, stillbirths 239. Facility contribution, level 4 had the highest number of live births and stillbirths. Trends, stillbirth rates remained below 2% for most years, but increased slightly in 2024, that is 2.07%. Most babies survive birth, but the 2024 stillbirth increase indicates an area for quality improvement. Under maternal death trends from 2018 to 2024, we never had any maternal death from 2018 to 2021. We only had 3 maternal deaths in 2022. Then from there on, we never had any up to 2024. These maternal deaths all were recorded in 2022. Maternal survival, we had 14,880 mothers survived, indicating excellent care in Ugunja sub-county. Facility contribution, level 3 and 4 manage the majority of maternal cases, and maternal mortality ratio is extremely low, that is 139.6% per 100,000 in 2022. Maternal mortality is minimal, reflecting effective management and quality care. Baby discharge rate from 2018 to 2024. In 2018, we discharged 98.8%. In 2020, all our babies were discharged alive at 100%. In 2024, discharge rate was at 99.9%. Discharged babies were 14,483 out of 14,561 live births, which is 99.5%. Facility contribution, level 4, accounted for most discharges. The trends that we noted, discharge rates consistently at 99.5% with minimal discrepancies between live births and discharges. Postnatal care is highly effective with nearly all live-born babies successfully discharged. Discussions. Service utilization, 74% of deliveries at level 4 facilities were noted, and there is also underuse of level 2 facilities, which is just 1%. Delivery trends. There is a dip in 2020 to 2021 linked to COVID-19 disruptions, but this was recovered by 2024. Neonatal outcomes, 98% live births and stillbirths rose to 2.07% in 2024. Maternal outcomes, we had 3 maternal deaths in 2022, but maternal mortality ratio is 139.6 per 100,000, well below the national average of 362 per 100,000 live births. Discussion/implications, facilities. 2, improve quality intrapartum care, monitoring and emergency response. 3, maintain resilience by addressing system vulnerabilities. 4, enhance postnatal follow-up beyond discharge. Conclusion, maternal use has increased with very low mortality, most cases concentrated in referral hospitals. There is slight rise in stillbirth, which signals quality gaps. There is also, we need strengthening lower level facilities remains critical. Recommendations, strengthen lower level facilities, that is level 2 and 3. We should equip and staff them adequately to reduce overdependence on level 4 hospitals. Improve intrapartum care quality by scaling up emergency, obstetric and newborn care, training and introduce continuous fetal monitoring to address rising stillbirths. Institutionalize maternal and perinatal audits, that is regular MPDSR reviews to identify and prevent avoidable deaths. Policy and data strengthening ensure sustainable financing for free maternity services and improve HMIS, KHIS data quality for evidence-based decisions. Thank you.
Thank you so much, Maureen, and congratulations to Ugunja. You are doing very well. Your boss is listening. Issues of quality improvement, very, very key. 2024, we must find out what happened. Now we move to Nyakach, Kisumu County. Your boss is in the house. He wants to hear how you are doing in Nyakach sub-county.
All protocols observed. Good afternoon. My name is Priska Kiprono from Nyakach Sub-County, an HRIO at Katito Sub-County Hospital. So our topic is maternal complications and perinatal deaths trends in Nyakach and Katito hospitals, period of 2018 to 2024. So the authors of this manuscript is Sarah Ajuang, and help from Otieno Jerusha and Beldin Omondi. So our introduction, perinatal mortality, which includes stillbirths and deaths within the first week of life is a key indicator of maternal and newborn health. Globally, an estimated 4.5 million perinatal deaths occur annually, with the vast majority taking place in low and middle-income countries. The sub-Saharan Africa bears a high burden, recording rates several times higher than those in high-income regions. In Kenya, perinatal mortality remains a major public health challenge, despite the introduction of numerous maternal and child health interventions. A significant proportion of perinatal deaths are linked to preventable or manageable maternal complications during pregnancy, labor, and delivery. This includes the hypertensive disorders, postpartum hemorrhage, obstructed labor, infections, and complications from preterm labor. Such conditions were not promptly identified and effectively managed, compromise fetal well-being, and increase the risk of stillbirths and early neonatal deaths. Continuation and understanding the patterns, causes, and outcomes of maternal complication in these facilities between 2018 and 2024 is crucial for guiding targeted interventions, strengthening maternal and newborn care, and achieving national and global targets such as the Sustainable Development Goals, that is 3.1 and 3.2, on reducing maternal and newborn mortality. The study has never been done of perinatal deaths within Nyakach, so it's the first time. This study seeks to address this evidence gap by examining maternal complications and their relations to perinatal deaths in Katito and Nyakach hospitals over the specified period. Our problem statement: perinatal mortality remains a significant public health challenge in Kenya, with maternal complications accounting for a significant proportion of stillbirths and premature deaths. The main cause of these adverse outcomes include conditions such as hypertension in pregnancy, obstetric obstruction, sepsis, and long or complicated labor. Despite the introduction of maternal and newborn health intervention, hospitals such as Nyakach and Katito continue to report significant perinatal mortality rates between 2018 and 2024, as evidenced by facility records and KHIS reports. However, there is a limited empirical data to analyze the patterns, the magnitudes and trends of this complication over time, and the underlying contextual factors that influence them. Our broad objective is to determine maternal factors associated with perinatal deaths at Katito and Nyakach hospitals between 2018 and 2024. Our specific objectives were to determine the maternal complication and perinatal deaths in Nyakach and Katito hospitals 2018 to 2024. The second one was to assess the trends between the trends before COVID, that is 2018 to 2024 March, during the COVID period, that was 2020 to 2021, and after COVID, that is 2022 to 2024, in perinatal mortality at Nyakach and Katito hospitals. The third one was to compare the perinatal deaths between the two hospitals within the study period, that was 2018 to 2024. Our study methodology, the study design, this was a retrospective descriptive study using a secondary data derived from a routine health service records reported in KHIS for the period of January 2018 to December 2024. The study examines maternal complications and perinatal deaths reported at Nyakach Sub-County Hospital and Katito Sub-County Hospital. The analysis was structured around 3 periods based on the timeline of the COVID-19 pandemic in Kenya. That is pre-COVID, the January to 2018 to February 2020. The period before the first confirmed COVID-19 case in Kenya, and before associated health system disruptions. COVID-19 pandemic period March 2020 to December 2021, beginning with the first confirmed case in Kenya and covering the period of widespread epidemic response measures, including the movement restriction, curfews, and service delivery disruptions. Post-COVID-19, that is January 2022 to December 2024, the period after the major restrictions were lifted with gradual restoration of routine health services. Our study area, the study area was conducted in Nyakach and Katito hospitals, both located in Nyakach sub-county, Kisumu County, Kenya. Nyakach County Hospital serves as a level 4 facility with a catchment population of approximately 8,211. While Katito Sub-County Hospital is also a level 4 facility, serves a population approximately 22,893. From the Nyakach Sub-County target setting, which is derived from the Kenya Bureau of Statistics 2019. Both facilities provide emergency, obstetric, and newborn care services. The study population. The study population consists of all reported deliveries and perinatal outcomes from the maternity units of the 2 hospitals within the study period. Inclusion criteria. All deliveries reported in KHIS for Nyakach and Katito Sub-County Hospitals from January 2018 to December 2024, including both the live births and stillbirths and records of maternal complications associated with those deliveries. Exclusion criteria. Records were outside the study period, that is the January 2018 to December 2024. All other records, including those with missing values for some outcomes variable, perinatal deaths or maternal complications, were retained to ensure accurate calculation of denominator, total deliveries, live births, and valid trend analysis. On data sources and variables, data were extracted from the KHIS web portal for the specified facilities and the study period. KHIS data are routinely collected at health facilities through MOH registers and aggregated monthly into the national system, making them both routine health data and secondary data for this analysis. The following variables were obtained. One was the maternal complication, that is the obstetric hemorrhage, hypertensive disorders in pregnancy, that includes eclampsia, sepsis, obstructed labor, ruptured uterus, prolonged labor, and other complications as defined in KHIS indicators. Perinatal deaths, that is a fresh stillbirth, maceratal stillbirths, and early neonatal deaths within 7 days of birth. Other variables were total deliveries, live births, and facility identifiers, that is for Nyakach and Katito. KHIS indicator definition were used for standardization of terms and comparability over time. Data analysis. Data were analyzed using the Microsoft Excel and SPSS. Descriptive statistics, that was the frequency, proportion, and rates per 1,000 total births, were generated to summarize maternal complications. And summarize maternal complications, deaths by year and hospital. We also checked on the trends for the period, then comparison of the facilities. So we had the results. The first one was to identify the maternal complications among the 2 hospitals. And from there, we can see the complications for the periods were 509, while the perinatal deaths were 110. So this is just the next slide that shows the segregation of the complications, that is the PPH, sepsis, therapy at uterus, eclampsia, in the two hospitals. So in the next objective was to assess the trends, and yes. So as we can see from the graph, there were some downs during COVID. The complications were less. Then it rose in 2022, then to 2024. And the deaths as well, there's downs in 2019, also in 2022. So this graph also shows the trends for the two hospitals. That is the 2018-2019 and pre-COVID, during COVID and then post-COVID data. So the third objective was to compare perinatal deaths. And we can see for the two hospitals, Katito leading with 59 and Nyakach having 51. So that table shows the deliveries, total number of deliveries within the study period, the live births, the number of deaths for the two hospitals as shown. So in discussion, maternal complication and perinatal deaths. Before COVID, complications from the two hospitals were 143, and it dropped to 120 cases during the COVID. That was 2020-2021. It increased to 246 post-COVID. And the perinatal deaths were 36 before COVID, and also during COVID time, that is 2020-2021. There was a slight increase to 38 deaths, perinatal deaths post-COVID. And on the trends of perinatal deaths, pre-COVID, they were higher at Katito, that was 23, compared to Nyakach, that was 13. And during the COVID, the perinatal deaths at Katito reduced to 17, while Nyakach increased to 24 during the post-COVID. The perinatal deaths in Katito went higher again to 36 after COVID. Then Nyakach also to 25. Katito had higher because it serves both the urban and rural. While Nyakach is the hub, and that's why it increased after COVID. However, we think that there is need for further investigation to fully find out the factors influencing the observed trends. On comparisons of the perinatal deaths from 2018 to 2024, the perinatal deaths are more in Katito, that was 59, and Nyakach, which was 51. The total live births for the period for Katito were 4,319, giving us 1.37% death rate. And in Nyakach, the live births were 4,170, giving us a death rate of 1.22. Which is still more than the recommended of less than 1%. The findings, there was an increased number of maternal complications post-COVID. The second one was the increased perinatal deaths pre-COVID. that is 36 during COVID 41 and post COVID 61 for the two hospitals. We think there is need for interventions. In Katito is leading with perinatal deaths due that it have the high catchment population compared to Nyakach, as it is located in the urban area. On recommendation, we recommend the county government together with partners come up with ways to reduce the maternal complications, e.g. coming up out with policy to ensure that all women of reproductive age are screened for pregnancy when they visit the hospital. If they test positive, they should start the clinic immediately, just like test and treat in HIV program, and the profiling to be done so that complications can be reduced. Thank you.
Thank you so much, Priska, for the presentation from Nyakach. Your DMS was away when we were saying at least there's something that is going on. People are already using the data that is available to conduct some research. And the fact that the project has a capacity building aspect, let's use it, guys, let's use it. Thank you so much, Priska. Now we go to game as we finish our ground presentations. Lucia Tandy is going to take 10 minutes, she has promised. And then when she's presenting, kindly write down your questions so that we save on time. Write down your questions and indicate whom you want to address that question so that as Lucy finishes, we'll have Karen come back to speak about early analysis as we wrap up to go for lunch. So please, let's write down our questions, indicate whom you want to address that question. Lucy?
Good afternoon. All protocol observed. I'm standing between you and lunch, so I'm really going to move very fast. So this is Game Sub-County in Sia County. Our topic was on maternity service utilization trend between 2018 to 2024 in different facilities in Game Sub-County, and we were a group of 4 people. So in the introduction, we are looking at the global situation, the African situation, and what is happening in Kenya, and also Siaya and Game Sub-County. So according to globally, it stands at 57. So that means that utilization is still a challenge even at the global level. At Africans, we stand at 53, and the situation in Kenya is increasing. Siaya too is also increasing, but Game, you can also see the trends. And there has been upward trend in Game according to KHIS from 2018 to 2024. So the objectives of the study, the general objective was to examine the trends. And we have the specific objective to analyze annual trends in delivery services utilization, to evaluate the trends on key maternal outcomes, to assess the discharge trends, and also to track birth outcomes. So what are our research questions? The first one was, what are the delivery service utilization trends? And what are the maternal outcomes? You're looking at what are the maternal outcomes, and what are the discharge trends, and also we are looking at what are the birth outcomes. So methodology, the design was a retrospective descriptive study. We were using qualitative data from KHIS. The study area was Game Sub-County, that is in Sia County, and health facilities. Then study period between 2018 to 2024. So our data source was Kenya Health Management Information System. The population, we are at women who assessed, the women who came to deliver in our facilities during the period under review. Then data collection, we extracted indicators. These are the admission, deliveries, birth outcome, and discharge structures, data abstraction tools for consistency. Then we had data analysis, we do it frequencies, percentages, and also in trends. We had ethical consideration, approval, and anonymization to protect the patient's confidentiality. So we are at the analysis, and this is after doing our analysis from 2018 to 2024. You can see the trend. There is upward trend, but in 2021, there was a distraction. I think during the COVID pandemic, there was a downward trend, but it was so steady from 2018. So we are talking about the levels of service delivery: level 4, level 5, level 2, and level 3. So in game, we don't have level 5, but we had level 3s. So maternal delivery, according to what I have, you can see how the level perform. And according to this, level 3 had the highest deliveries, followed by level 4s and then level 2s. Then these are the results. Level 3 had the highest at 46, then level 4 deliveries were 40%, and the least was level 2, contributed 14% of all the deliveries that happened during the period of under review. Then we had the birth outcomes. So this is baby outcome trends. These are the live births and stillbirths. So the downwards is the stillbirths. In 2018 to 2024, there was a decrease in the number of stillbirths and also increase in the birth outcomes. So this is just a trend on levels of the facilities. So according to levels of facilities, level 4s had the highest trend, the highest number of stillbirths, followed by level 3s. And up there, we had level 3s with the highest deliveries, but level 4s was following. But when it comes to stillbirth, level 4s are leading. Then we have the stillbirth rates. We had there's a decline from 20.7 to 8.8. That one is a good trend. It is a downward trend when it comes to the stillbirth rates. Then baby outcome results. As I've said, there was a steady decline over the 7 years. Then there was a fluctuation, a minor one in 2021. Then overall deliveries, Meira live birth trend peak in 2029. And then the trends of live births were plus 20.3. Then as I've said about the trends in stillbirths, what I've shared, that is just the narratives and the contribution towards that. So the contributions in level 3 was the highest. Facility contributions, the largest were 55 stillbirths in level 4, level 3 with 35. And I just want to bring to our attention that in game we have so many level 3s, up to 13, and level 4s were only 4 during the period of under review. So maternal deaths, we had 5 during this period. We have from 2018 to 2021, there was no maternal death, but we had 1 in 2022, 2023 we had 2, and also 2024 we had 2. And this is just a table form of the maternal outcomes, the total deliveries and maternal deaths. So that's just a description of what I've said. And then we have discussions, delivery trends. Delivery rose from 2018 peak 2023, slight drop in 2024. So the contributions and the outcomes, the maternal deaths recorded 2022 to 2024, and the rate of maternal death is below 362. That's concentrated in level 3 and level 4 facilities to high risk referrals. Still, we are talking about the birth. The stillbirths decline. There was a decline by 57% and live rate increased by 98.6. Majority of stillbirths are in level 4 and level 3. So the key insight: increased utilization, guaranteed better outcome. Quality of care remains a major challenge because of the high number of stillbirths, and also in the years where we are still having maternal deaths. Then we really need to look at the quality of care. Then disparities persist across facilities. So what are the implications? Free maternity health care improve access, but quality must also match. Strength lower level facilities with skilled staff, improve referral systems, and emerge response. And we can see in level 4 we had not higher deliveries, but stillbirths are so many. Reason, maybe because of the referral system. The most complicated cases are taken there. So we really need to improve on our referral services and emergency response. Then we need to sustain community engagement for timely care seeking. The healthcare behavior seeking at the community level must be strengthened. Then we have the recommendation. One of the recommendations is to strengthen the quality care. That is, one of them is to implement maternal death surveillance and response audit, improve staffing ratio, and also train healthcare on EMOC. Capacity building of level 2 facilities, that's another recommendation. So what are we recommending? Equip lower facilities with skilled birth attendants and basic emergency equipment. When they are equipped, referrals will always reduce. Then strengthen also referral system to ensure transfer of risk cases, a timely transfer. Another one is community engagement and education. Intensify awareness campaign on importance of antenatal care, timely capacity delivery, and postnatal follow-up. Work with community health volunteers to track and support pregnant women. Then we have policy and resource allocation. We really need to allocate more resources to maternal health, prioritizing Gape Sub-County growing demands. We are still having 5 maternal deaths, and this really needs a lot of support, and also integrate maternal service utilization data into county level planning for evidence-based decision. Continuation is continuous monitoring and research. As we continue in monitoring and evaluation and research, we also need to track maternal and neonatal outcomes to detect early warning signs on adverse trends, conduct further research on barriers to utilization and gaps in service delivery at community and facility level. So these are the references, and thank you.
Well done, Lucy. GAME is also doing well. I like the issue of referral system, because many times we blame Pumwani, Nairobi, for having too many, Kenyatta, not Pumwani, because Pumwani will refer patients when they are about to go to the other world. And so the deaths are counted in Kenyatta, but the problem started elsewhere. Thank you so much for the analysis. Makes so much sense, and we appreciate. Now we want to bring Kiran back to just speak about the initial analysis and early findings in 10 minutes or less. Then we can have those questions brought to us. Adino was going around to pick the questions. There's already a question here. Please pick the question so that when Kiran finishes, we'll have like 2 minutes to discuss the same. Please write on top who is supposed to answer the question. Thank you.
I can now say good afternoon, everyone, rather than good morning. So I'm going to go through this as quick as possible for you, because it's very much lunchtime. So if I could have my slides on, please, and I'll get through this as quick as possible for you. But essentially what I've been doing is following on from the previous presentations, is I've been looking at the data, the trend data, but from a high perspective. So whilst they've been looking at sub-county and county perspectives. I've been looking at it from a higher level, and there's a lot of things to learn from those discussions. And these are very early findings because I've only been looking at this data for the last month or so as well. So once I have my slides, I will be able to continue. Pardon? You didn't have the slides. I thought I shared them.
The slides were not sent, maybe not shared, so could we have the questions so that whoever is supposed to answer can do it so that we save even on time? The questions, sorry Kiran for disrupting your train of thought. Standing here is not easy. People think it is. So we are really sorry. But let's have the questions so that we start as it comes.
Thank you. So if we could just jump forward a couple of slides, please, just to aims. So there's, so next slide, please. So the aims really are to use large-scale routinely collected healthcare data to showcase the ability to inform practice and policy. So we're looking at direct impact effects of COVID-19 on maternal, newborn and child outcomes, child health outcomes. We want to know which subgroup populations are most at risk, and has the effect of COVID been mediated or moderated by, socio-demographic factors or contextual factors and so on. But at the moment, I've mainly been looking at trend analysis, and that is essentially what I'm going to go through today. So next slide, please. So just to briefly explain, it's the same data, again, that has been discussed. So we've got 84 months of data, so over 7 years from January 2018 to December 2024. And I've been looking at data across the ECHIS data, so the Electronic Community Health Information System, and also the KIHS data, so the Kenya Health Information System. So this is both maternity and antenatal care data across multiple sub-counties, as you can see there. I'll skip through the next few slides to go to data flows. So from the outcomes, we can try to define data flows that show differences in the outcomes over time. So for example, I've got birth data here. So this allows us to compare rates rather than counts, because if, for example, we had 50 in 1 month versus 100 in the next month in counts, we don't know whether the increase is due to an underlying increase in the denominator or so on, whereas a doubling in the rate of 0.2 to 0.4 is a marked increase that should be noted and be investigated. So here, creating deliveries as the denominator, and then we have different delivery outcomes from that. So your normal delivery, cesareans, assisted, vaginal delivery, and so on. So then the second slide for data flow, so the next slide, please. Again, we can look at another data flow here. So we have all deliveries again at the top, but we can split this by live births and stillbirths to look at the rates again. Of the live births, we can then construct it to look at the rates of low birth weights, preterm births, and those children born with deformities. And then of those, we can then look at discharge alive, and we can look at the difference between fresh and macerated stillbirths as well. So it's how can we use this data best? So just got some data summaries briefly here that I'm not going to go over too much, but essentially just to say that normal deliveries most popular, most frequent 84.4%, and then the other considerable category is caesareans, which make up about 96-97% of all outcomes between them. And the data here across all of the sub-counties across the 84 months is on a roughly 330,000 deliveries, so it's a good amount of data to look at. So jumping to trends over time, so I kind of whizzed past the data, but there was 86 different outcomes across all of the data formats, and 43 of those we have across the whole 84-month time range. So I just tried to pick out some to look at to start with. So these are at an overall perspective. They're not by sub-county or county. This is just looking at change over time. So we can see here with birth outcomes that we have a slight reduction in trend for normal deliveries from around 85% to almost 80% to a 5% reduction over the 7 years, whereas caesareans are slowly creeping up at the same time, with all the other outcomes remaining pretty flat over that time. So specifically, we've got a 7.4% reduction in normal deliveries from month 1 to month 84, and then from month 1 to month 84 for caesareans, we've got a 7.6% increase. So the outcomes are almost accounting for each other. Next slide, please. So again, looking at live births versus stillbirths, we can see that we've got a pretty flat rate over time, where you notice a small dip around the start, towards the end of 2021, the start of 2022. Again, it'd be interesting to hear what people's thoughts on what this might be. It might just be it's a sub-county specific. We've been seeing that from the other presentations, that there are differences between them. So I haven't gone into that level of detail yet, but it's been interesting to see from the other presenters that there are some differences that are worth looking at as well. Next slide shows HIV positive deliveries over time. So the highest rate is in month 4 of 15.1% within the data. And then the lowest rate is at month 74, so 70 months later, down to 6.5%. So a big drop. And I think if you just go through the slide, I've put 2 lines on there to show there's a reduction in rate there until that month 74, and then if you press it again, we've got a flattening of the rate across the end. So something happened between 2018 to 2022 that reduced the rate of HIV positive deliveries, and now they've leveled off and plateaued. And it'd be interesting to hear what people might hypothesize that being the cause of that being. Next slide is looking at revisiting ANC clients. So this is mothers returning to have multiple sessions. And if you could just click again for me, we can see that well, you don't need me to point it out to you, but you can see that here in January 2021, we have a big drop in the amount of mothers that were revisiting the ANC clinics. There's an overall slight trend increase over time, but again, we've got this reduction around January 2021 that then slowly creeps back up over 3 or 4 months. Yeah, I've seen that. So then also to agree with that on the next slide, we've got the supplementation that the mothers were receiving in their antenatal clinic visits. So this is looking at combined supplementation. So this is both iron and, I don't know what the other one is now, off the top of my head, sorry. But again, we see a similar drop in trend at the January 2021 point, which corroborates with what we've just seen for revisiting ANC clients. And then after that point, we do see this reduction in trend. So, you know, this is something that I'm going to be looking at in a bit more detail. And then the next slide, I picked out birth outcomes, so normal deliveries and caesareans, and split it by Kisumu and Siaya counties. So the blue colours are Siaya and the orange and yellow are Kisumu. So we can see that in Siaya we've got a consistent increase in rate of normal deliveries compared to those of in Kisumu, and then from the bottom, you can see that we've got a high rate of cesareans in Kisumu. Up until for most months, that's a consistent outcome, apart from around the end of 2020 to the start of 2021, where we see the rates almost being the same. So this is just, you know, a look at the data. I'm trying to say, oh, this looks like something might be happening, something might not be happening. Well, what we can do is we can implement a statistical technique called join point regression. And this is a technique to model trends over time at specified intervals. So we're trying to measure over a segment of data the amount of change that goes on within that period. So if we could have the next slide, please. So essentially what we're trying to do is we're trying to optimize something called join points, which are segments within the data range which create segments of data. So if we have 2 join points, we have 3 segments and 3 trends over that time. And what this does is it allows us to see positive versus negative changes, and we get an indication of the size of the effect. And when we're looking at rates, this will be change in %, for example. So at this moment in time, I've only been able to carry out one of these analyses. So using specific software to run these models for HIV positive deliveries between 2018 and 2024. As I said before, there was a decrease over the 84 months. And what the model predicted is that the optimal fit for join points and separation of the trends over time was so having 2 join points, one within September 2020 and the second in May 2021. So from January 2018 to September of 2020, we see a monthly percentage change of minus 0.4% in the rate of HIV positive deliveries. Then from September 2020 to May 2021, we see a reduction of rate of 2.63%. And then from May 2021 to the end of 2024, we then see a similar reduction in rate of that we saw within the first segment. So we have a strong reduction in the amount of HIV positive deliveries that were occurring within that period. The reason behind that, if anyone has any insights or thoughts about this, please come and find me and discuss these things with me, because I'm learning a lot about this and this is all very new to me. So I would love to hear people's insights, people on the ground who work in this. So my next steps, very simply, carrying out further join point regressions using the aggregate data, but then also my next analysis will be looking at the individual data that we've got, so the maternity data that I was referring to earlier, and also the antenatal care data we're going to get as well. And that will be looking at more sophisticated modelling to look at hierarchical structures within the data and looking at trying to actually infer potentially what has been going on and mediating effects over time between variables. I have some general conclusions, and then I've got some other points that I wanted to discuss, but in the interest of time, I will leave it there. Thank you.
Thank you, Kiran. Sorry for harassing you. I'm sure you had so much to say, but at least you have promised that you will continue the analysis so that we can validate what our colleagues have been talking about. There are many questions. I'll give each presenter 2 minutes to just address their area, and then we conclude. So we'll start from the end. Please come, 2 minutes to address your area. This thing, unless...
So for Alego Usonga, the issue concerning the 30 maternal deaths, as we know, Alego Usonga is a mother facility, is a referral healthcare facility whereby we receive referrals from various healthcare facilities across the county in Siaya. So the major issue that might have led to this rise in maternal deaths can be due to referral system networks, whereby the level 5 facilities are pressured with a lot of referrals from other sub-counties and also from the lower levels in the sub-county. So as a county, we are working towards improving level 3 and level 4, whereby I've seen they have upgraded some of the level 4s to sub-county hospitals to be able to manage these referrals so that we don't put too much pressure on the level 5 facilities alone to handle this pressure. I believe in the near future ahead, we are going to improve on this issue on maternity, on maternal deaths, because it is not an issue to laugh about. It is a serious issue that as a county, we are working to eliminate it and ensure we have 0 deaths going forward. Another question was this study done in public or private? But for Lego Usonga, we did this study in public and faith-based facility. Thank you.
Okay, for this is Game Sub-County, but this is for all. Question 1, we can as well get answers from the group, but I'm going to answer some. So we work as a group and we truly need your support. So question 1, were the data collected from paper source or from electronic data or both? This one, I'm taking it back to the groups. Dottie, can you talk to us? Question 2, as she's given microphone, how much of the stillbirth maternity mortality was due to, like the patients and the health? So one thing I want to say that the stillbirths in our registers, there's no place for the cause of the stillbirths. So in the registers, the indicator that we only have macerated stillbirths and fresh stillbirths, but we don't have the cause. So we really need to improve on the registers so that we understand. But what is the macerated and stillbirth? Stillbirth, these are children that are being born dead. Like macerated, they died in the womb and there's a delay, the child is peeling over of the flesh, the skin is peeling. But fresh is a child that has not died, it's just been born dead but still fresh. So we always don't have in the registers where there is indicated the cause of this stillbirth. But in terms of maternal mortality death, in game the cause was PPH. That was the cause of this death. And this, we also talk about the late referrals are the causes of these deaths. Because when a mother comes to the hospital early, the chances that this mother will die is 0 because they will try to manage it. But when there is a late referral, maybe the mother is being brought almost dead, what happens? So that is why you see that in our referral hospitals where the deaths are taking place. So the source of data collected, this data was collected from registers. But because of the time, the cleaning, we did not do cleaning on time. So we resorted to use the Kenya Health, the KHIS, Kenya Health Information System, to present because of the challenges that we found when we were doing cleaning and the time was not on our side. But data was collected manually from the registers, but due to time constraint, we resorted to retrieve data from the system, that is KHIS, and do our analysis. Thank you. That is what GAME did. I don't know about the other sub-counties. So the last question is for all, for GAME. How can we project the future given the finding trends? That is what policy is all about. How is the future looking like So because we work as a team, I'm not going to answer this, but I'm going to support George to answer this for us. So what is the future? We talked about the referral, improving the referral system. We talk about the coordination at the community level. We talked about the increase in funding on maternal. So if all these are done, because we are seeing the trend is higher, there is an increase, but we still have so many stillbirths and maternal deaths. So how is the future? I'm bringing it back to my team so that George can help us answer that. Thank you.
Okay, thank you so much. We will wait until the other two speak, and then we'll have Zachary from Kisumu to support the team and George from Siaya to speak. Yes, we'll give you a chance. So, Nyakach.
Nyakach, we have only one question. That is why we chose the two facilities and not the other private facilities. So the reason as to why we chose Katito and Nyakach is because these two facilities are high volume facilities within Nyakach, and they record high number of deliveries. They also receive the referrals from other referral facilities. Nyakach being the hub facility and Katito being the mini hub. So that is why we decided that we do this project on the two facilities first, but we will work on the rest.
Thank you, Nyakach. Now, finally.
Thank you for the question. The question we have for Gunja is that, did we collect data from both public and private facilities? The answer is no. We concentrated our study on public 9 health facilities in Ugunja sub-county. Thank you.
Thank you. I'm sure after recommendations from the initial pilot, we'll be seeing that we need a complete picture of a county, so we may go to both public and private. Zachary from Kisumu, please comment on referrals.
Thank you very much, Mrs. Oyuer. I'm happy to be with you. You are my former boss. You know you are so watoto wako walikuwa wengi. When you are the national office, we was in the facilities, and we thank you very much for having taken care of us at the national office in Afya House. So I'm Zachary Ukech. I'm the Kisumu County Referral Coordinator, and I've been touched by the very many presentations from the sub-counties based in Siaya. And I wanted just to share with them, but before I do that, I wanted to ask Siaya County representatives, do you have a referral protocol and strategy in place? It is there. Yeah, so I wanted just to give you something little on how we've done ours, because it is answering very many concerns on the bottlenecks that have been mentioned here on referral. Under support by our beloved Governor of Kisumu County, His Excellency Professor Nyang'o, he launched referral services and Emergency Operations Center in 2022. And to date, we've really had a paradigm shift, and we've really improved, as you've heard. Maternal cases have not been very many in Kisumu, but challenges are cross-cutting, just as in Siaya. So we've had a referral protocol. We developed a referral protocol and strategy, mainly to address the maternal death issues, the challenges that come along with it. And we developed a referral framework matrix that had 7 points. Number one is to upscale or scaling up of expert movement. And somebody mentioned it in a sub-county. In this, there should be a timetable put down that is followed by obstetricians and gynecologists, so that they go to the community level for reviews, reviewing the patients that have been selected for review on specific dates at the community-based hospitals, so that this one reduces even the very many referrals that are done. Then through this, the very many theaters that we have in Kisumu County to the community-based hospitals that in almost every sub-county, surgeries can be done.
Please summarize.
Time is short. Okay, let me just go fast. So we also have, apart from expert movement, client parameter movement, we have a digital platform which we use in communicating patients' parameters. And of late, we have doctor-to-doctor communication from the referring facility to the refusing facility, so that communication is enhanced. It has been the nurse-to-nurse practice, but we find that there have been certain issues. Another one, along with client parameter movement, we have a toll-free number, which I believe CI also has, that members of the community can use to call without being charged airtime for effective communication. So the person at the community level can even rings EUC direct, and then the EUC rings the lower facility to be ready to receive such a patient, assess and do pre-referral, adequate pre-referral care based on the capacity building that colleagues talked about, and then they are referred accordingly. Another one is scaling up of health products and technologies. I don't know whether you have drone services in Siaya, because here in Kisumu, we use drone services so that even, for example, a mother might be at a hospital where she can be taken care of, but there is severe anemia. So drones can drop blood to such facilities quite timely, and care continues, and death is avoided. Another one is on specimen movement. With this matrix, we tend to purchase adequate motorbikes that will be helping to transport specimen for testing. So at the nearby hubs that are adequate, that have adequate laboratory services, so that care can just continue at a level that has got challenges of adequate laboratory services. Thank you. This is what I wanted to share.
Thank you
and
so
thank
much.
you very much.
George, you take 1 minute to speak about what does the future look like.
Thank you so much. My name is George Adiedo. I'm a nurse by profession. What the future looks like, I'm from Game Sub-County. In our presentation, we said that level 3 facilities are the leading with 46%, followed by level 4 and 2 in terms of deliveries. The future is bright, and I attribute it to 3 reasons. Number 1, the county now is doing what you call capacity building of the staffs through taking us through the EMOC training. Number 2, we have increased staffing. Waziri can bear me witness, is here, and our MOH. We have increased staffing in both level 3s and 2, making the future to be bright. And lastly, we have the county has invested also in the infrastructure, We have new maternity. As for my place, the maternity was renovated this year. So looking at the future, we find it bright. I can also give it to MOH for 1 minute to just say something on that.
Thank you very much, the moderator. Thank you, George, and thank you, Team Game and Team Siaya. About the future of our outcomes in game, again, it's paramount to note that with the support of the county, we now have a resident obstetrician, gynecologist resident within game. Actually, he's the medical superintendent for Yala Sub-County Hospital, which is our mother hospital within game. And again, recently we had 2 additional health centers upgraded to the status of a hospital. Now game will have 3 hospitals domiciled within game, covering the upper part, the central part, and the lower part in South Game. And I know with all that together with every other compounding factor put into the fore, our mothers and our babies will have the best of care. Again, the county has supported a number of our staffs, and recently we even had a clinical officer proceeding for higher national diploma in pediatrics and child health care. And we know when she comes back, she'll pump into the already existing staffing workforce that will give the best outcomes. So the future is no longer orange, but the future is extremely bright. And also for Kisumu County, we are very happy the points they've brought across. They came to benchmark in Siaya County, and we are very proud that they are doing very, very well on the same. Thank you very much.
Thank you so much, Bwana MOH. At least they benchmarked and they worked. And then the children have now gone beyond the dads. You see them, Kisumu, Europe. Nani kama hawa. Thank you so much. I know I'm standing in between you and lunch, and I would not want to say anymore. This morning we were supposed to just check how to measure what we do. And I think we have done it theoretically, and they have said it practically, and Kiran is going to make it even better when he does further analysis. And with those very many remarks, my time and your time is about 12:30. 12:30. So we'll take 45 minutes for lunch, or we do 30? Consensus? 45 minutes? No, your clock is wrong, Bwana Waziri. Your clock is wrong. Mine is right. Mine is right. So lunch is 12:50 to 1:50. Is supposed to be 1 hour. Let's make it 45 minutes. And let's pray for the lunch. Our Father and our God, we thank you for the provision of lunch. We ask that you bless it as we take it. In Jesus' name we pray. Amen. 1 hour, exact 45 minutes. Let's be back and start. So sorry for the delay, but I think it got sweeter and sweeter.
and everybody else is invited to carry on with some of the activities, mainly involving poster sessions, which I believe are in the next room. So I think for today's session, it's going to be facilitated mainly by my colleague, Kieran, who is sitting at the far end. We want to make it as interactive as possible. We want to make it very informal so that just to encourage participation from everyone. So he'll be guiding the discussion from the far end. And I think the seating arrangement works perfectly okay so that we're already in groups, and it will be possible to continue the discussion in groups even as we go through the formal sessions. This will involve going through some of the analytical processes that you can use to further analyze the data, and also take you through some practical sessions, making use of the software that you've already started using, SPSS, and then trying to see how you can build on what you know already to carry out more advanced analysis to strengthen the evidence that you are going to use for policy or to inform the decisions. So thank you very much. So at this point, I think we'll request those who are not part of the capacity building workshop to join the next session, which is on poster session, and everybody else involved in capacity building will remain here. We'll see whether it's necessary to rearrange the seating just so that it works best to encourage participation from everyone. Thank you. Are you going to be involved in the capacity building workshop? Do you want to remain here?
To learn.
Okay.
I've never experienced this, so
Yes,
I don't
okay.
even.
That's great.
I'm trying
That's
to
great,
learn.
and I think sometimes it's useful to get different perspectives as you're going. That's great. Yeah.
So, do you want to do something?
No. I was just trying to invite the others who are sitting far end to move closer, and so they'll join you. Yeah. So maybe you can just join that table which has just one. Yeah, it has just one person, and yeah. Do you want to be involved in the capacity building workshops? I can just ask others to come and join you here as well. We're just trying to, I think maybe that one so that you can, or you want to say hi to him?
And the
Yes.
team that is out, Prof?
Sorry?
The team that is out, the team that is in the
Oh,
exhibition.
there's a poster session which is going on at the same time because we had only a few people who could be accommodated to share their experiences, which we did during that. So some of the analysis that have been done are being shared in a poster session. Yes.
And the group remaining here?
For capacity building workshops, which started already. Tich had run.
It's already ongoing.
It's already ongoing. In fact, all the work they presented was part of that capacity building workshop, so they had already started analyzing the data and sharing. Yes. Yes, they have. Yeah. So. Sorry to disturb you. Do you mind moving maybe to this table? We're just trying to get people close enough to mind to make the discussion a lot easier. I'll remove some of this.
up to speed. And then move to hypothesis testing, p-values, confidence intervals, and linear regression. So just to begin with, just to kind of have a neutral starting point, I'm just going to go through data types again. So we have many different types of data that a variable can conform to. So we have either categorical or numerical outcomes. So categorical outcomes, these are either nominal, where you have numbers or labels that stand for a category, but there is no order or value within that. So male and female is a good example, and this is also a binary variable. And then we have ordinal, which is the step up from that, because we are assigning a rank to the data. So if we use pain severity as an example, 1 would be no pain, 2 mild, which is more than none, 3 moderate, more than mild, and 4 being the most severe of them all. On the other hand, we have numerical outcomes. So we have our discrete data, so observations that can only take certain numerical values. For example, counts of events. We wouldn't expect to see half of a death, for example. It's full discrete values. Number of pregnancies, number of GP visits, they're all exact counts, discrete values. And then after that, we have continuous values, which take some form of measurement across a range. So, weight, we could have 70.5 kg for an adult. We could have height of 174 centimeters and so on. So they are very much across a range of values and not discrete. So what type of analysis exists? Well, to start off with, we have our descriptive analysis. So this is where we're trying to summarize results from sample frequencies and proportions. We might be interested in taking the mean and standard deviation, maybe the median and percentiles from continuous outcomes. And also, we want to visualize what the data looks like. So you may plot bar charts, line graphs, pie charts, even though I'm not a big fan of those. But you're trying to have an informal look at the data without actually making any concrete decisions from it, because you aren't actually testing anything from the data. That then leaves space for inferential statistics, which is where you're trying to use information about a sample that you've drawn from a bigger population to try and draw inferences back to that population. And this is all based on probabilities. So given that I'm going to be talking about linear regression, my focus here is going to be on interval and ratio data. So what kind of descriptive analysis do we have? So we have the arithmetic mean, measure of central tendency. So we sum all the observations and divide by the number of observations. We have the median, which is the midpoint of the observations when arranged in order. That's often useful when you have skewed data because you remove outliers at either end. So wealth data is a particularly useful case for this, because you remove really high earners, which a mean would be biased by. And then we have the mode, which isn't used very often, and not many analysis techniques, if any, use the mode, but this is essentially the most occurring value. We can get these measures of central tendency, but around these we need to have an idea of how much variability there is around those. We want to know how much variance, which is a term often used. We want to know how much variability there is around these measures. So we have variance and standard deviation. So the larger these two measures, the more spread out the data is around that point. And then for the median, we also have the range percentiles. So we can specify specific percentiles if we want to look at taking 5% off either end and look at the middle 90% of the data, or the interquartile range is then the 25th and the 75th. We're looking at the middle 50% of the data. So that's a measure of variability around a median. So moving on from descriptive statistics. Anyone have any questions about descriptive statistics before I move on? I think you've kind of covered all of those things anyway. Just to say, if anyone does have any questions, this is supposed to be informal. Just throw your hand up, ask me questions. I want people to be involved. So moving on from descriptive statistics and talking about inference, what are we doing fundamentally? Well, we have a target population of interest. You know, we're saying we've got all of these people within our target population here, and what we want to do is we want to take a random sample of these people, which we see here, and then from that sample we want to be able to try and figure out something like a mean of an outcome that we're interested in and how much variability there is around that, to then use that information to then infer back to the population. That's essentially the gist of what we're doing, so that's where inferential statistics comes from. We're trying to infer back to the target population from the sample, and the target population can be defined as many different things. It could be a specific age group of people, say mothers over 40, interested in specific outcomes around those. It might be people with certain health conditions, say cancer patients or so on. You then try and draw randomly from those to have a random sample to then infer from. And from that sample, we then, as I say, we can calculate our measures of central tendency. So we, you know, if we have a continuous outcome, so say we're looking at weight within a population of people with back pain, for example. We can take the sample mean, and that's a point estimate of the true unknown population value. It's not for the population. We don't know what that value is. We've taken a sample from the population because it's not feasible to collect all of the data on the full population of interest. If we could do that, we wouldn't need to do inferential statistics. So we have this unknown population value, but we know that it is a measure of a certain amount of the population. But what we want to know is how precise that estimate is. And using the sample that we have attained, we can determine a range of certainty or uncertainty around that estimate. And if people have heard of 95% confidence intervals, that is essentially what we're doing. So we're constructing an interval of confidence around the mean value. So as you can see in the graphic in the bottom left corner, we have our distribution of our data. So again, if we say this is a continuous outcome of height, for example, in the middle here, we have our normally distributed data, so this will be our mean value in the center, and then either side of that measure of central tendency, we have 95% confidence, essentially, that that value will fall within that. So this is a measure of the parameters for the population given the sample that we've collected. So a 95% confidence interval for the mean is a range of values determined from the sample data that we can be confident includes the true population value, so 95% probability. In a kind of a frequentist statistical manner, truly what we are saying is that in the long run, if we did this 1,000 times, we will capture the true mean 95% of the time. So we're not 100% confident, because if we were going to be 100% confident, our range would have to be massive, because we don't know the true ranges of the data, because that's why we're collecting this data. But we have 95% is a commonly used threshold to have a good amount of confidence in our parameters that we're estimating. You can use others, 80%, 90%, but 95% tends to be the norm. So some examples here. So consider a survey of 729 pain clinic users. And we've asked them all what their pain score is. So we've asked them from 0 to 100, what is your pain? Say that 0 is lowest and 100 is the worst pain you've ever experienced. And we then take the mean from that sample, and we have a mean pain score of 60.9. Okay, so that's fine. We know that from that sample. But then we want to get an idea of how that then relates back to the target population. So we construct our confidence intervals using the variability that we've got within our sample that we've extracted. And we then have a certain amount either side of our mean. So as I showed you here, it's symmetrical around our mean. And essentially, it's for a 95% confidence interval, it's 1.96 times the standard error of the data, either side of the mean. So we'll take this first example. We have a CI here, a 95% confidence interval of 57.7 to 64.1. So 60.9 is directly in the middle of this estimate, and we're saying that of the 0 to 100 scores, that we're seeing around 3.2 pain score, on the measure of pain score, a change in 3.2 either side of that. So you can then also say, well, this is quite a narrow confidence interval, so there's quite a lot of precision there, because if you look at the 3.2 with respect to the range of the scale 0 to 100, three either side is quite narrow. We also could say we asked the pain clinic users their percentage satisfied with care, so we can do this for percentages as well. So again, we're just collecting a continuous outcome. Our average satisfaction with care is 71.3%. So we'll say 100% is most satisfaction, 0% is no satisfaction. And again, we have a confidence interval of 68 to 74.6. So we're saying that of our population of pain clinic users, which we can't test because it's too big of a population, we've taken 729 of them, and from this data we can infer that between the overall satisfaction with their care would be somewhere between 68 and 75% essentially. And then another example, mean time between referral and appointment, so we'll say 4.5 weeks, again continuous outcome, and we get an idea of variability around that mean of a confidence interval of 2.3 to 6.7 weeks. So it's all about what is the mean value that we've got, and then how big is that interval around it. And confidence intervals also align with hypothesis testing, which is something that I will come onto shortly, because the threshold that you specify for your confidence interval, so in this case 95%, directly refers to the alpha level that you specify within your statistical testing. So what do I mean by testing? Why are we doing testing? Well, if we think about the target population again, so here we've got red faces and blue faces. We can say that the men are red and the women are blue. And what we're doing is we're saying, okay, from this target population, we're going to take a subsample of males and subsample of females, and we want to obtain information about those two groups to learn about the differences between them. And then we can then say that, okay, from this information that we've obtained from both groups, what does this mean within the population? So whereas before we were just looking at a direct point estimate for something, we can implement the same idea here and say, rather than a specific value of a scale or something, we can say, okay, what's the difference between two groups, and then how much variability is there around that, and then how does that reflect in the population? So let's look at some examples. So first example being the main pain score in females was higher, the mean pain score in females was higher than that for males. So if we say pain scores again 0 to 100, in females it was 60.16, and males it was 57.2. So we've got a mean difference of 2.94, and we've got a confidence interval around that of 0.89 to 4.99. So what we're saying is that essentially in 95% of cases, 95% draws in the long run from the population that the true population parameter would be within that range of 0.89 to 4.99. And again, we're not being 100% certain, we're only saying in 95% of cases, because we can't be 100% certain because we aren't testing the full population. So what's interesting about that? Well, you may have noticed that the lower bound for the CI of 0.89 is above 0. So we're saying that in 95% of cases that females always have a higher pain score than that of males. So in some cases it might only be 0.89 or 1 or 1.2, but in some cases it will also be 4, 4.5 and so on. And as I say, this is 95% certainty. We aren't, there could be cases where you could take a sample and do a comparison, and males could be higher, so you could have a mean difference of -1, for example. But in 95% of cases, we would expect the population parameter to fall within this range. Another example, so we'll look at percentages again. So females were slightly more satisfied with their care than males. So we'll say 67.8% of females were satisfied versus 64% of males. So the difference, 3.8%, quite a small difference. And given the size of the interval that's around that, given that there's about like 6.9% either side, we can see there's quite a lot of variability within the data. It's not that there is a clear trend between the two. We also see that the confidence interval also falls below 0, so we can say that actually there's probably no certainty in there being a difference between the two. And then final example of a mean pain score before attendance was higher than after attendance. So we have a mean scores of 60.9 versus 57.03, so a mean difference of 3.87, and again, both of them are above 0, 1.53 to 6.22, so quite a narrow band of certainty around that mean estimate, which we can then use to infer back to our population. So I've inferred a bit about 0 with these confidence intervals and so on, and that leads into proper hypothesis testing. So what we want to do is we want to construct a logical framework for testing all possible outcomes. We want to be able to say with certainty that there is a difference or there isn't a difference. And the way in which we do this is that we specify 2 statements of intent. So we have our null hypothesis. So it's a statement of no difference or no effect within the population. So for example, there would be no difference in pain between males and females that are consulting a back pain clinic. Another example, males and females have the same rate of satisfaction, or there's no difference in weight between those with back pain and no back pain. So we're setting the foundation for no effect between the two, and what we are then doing is we're testing against that null hypothesis using the data that we've collected to infer to the population, is there actually a difference between these two groups? Do we have evidence against the null hypothesis to say that there is a group difference? And as such, we have our null hypothesis, no effect. To complete the logical framework for all possible outcomes, we then have our alternative hypothesis that is a statement that there is a difference. So it's either one of the 2 outcomes. So as I said, we're assessing the strength of evidence against the null hypothesis based upon the sample data. And statistical testing involves computing something called a test statistic. So you may have heard of chi-square tests, t-tests, and so on. So from all of these, you have a test-specific test statistic, which together with something called degrees of freedom, you then can extract something called a p-value. And this is what is used to derive a measure of significance. And the way that it used to be done is that you would have to go to statistics textbooks and go to the back, and you would have big tables, and you would have to find your p-value for your analysis. But in modern day computing, programs will compute an exact p-value for you, so you know exactly the probability of there being a difference between the two. So an example here being 64% of males versus 68% of females were satisfied with their care. So what we're interested in testing for is there a statistically significant difference between the two? I.e., can we say that paying clinic males and females are not equally satisfied with their care? So is there evidence of a difference between the two? So here we have H0, so this is our null hypothesis, so no difference between the two. So we're saying that the percentage of males equals that of females, so they're exactly the same. And here on the right-hand side, you can write this as saying the probability of males is the same as probability of females. Aside from the null hypothesis, we have our alternative hypothesis. And here we are saying there is a difference. So we're saying that the percentage of males does not equal that of the percentage of females. So they're not the same. And again, on the right-hand side, we're saying that the probability of males is not the same as the probability of females. So we have our test that we may carry out, and we have our we get a p-value from this. So what is a p-value? So the p in p-value stands for probability, so it's a probability value. So we're saying it's the probability of getting our sample data when the null hypothesis of no difference is true. So we're testing against the null hypothesis. It's fundamental to say that the null hypothesis must be true, but we're essentially testing for evidence that is against the null hypothesis. But we've got this probability measure between 0 and 1. All probabilities fall between that. So what do we categorize as a significant finding or not? Well, many moons ago, a statistician, it might have even been a psychologist actually, recommended that 0.05 as a p-value is suitable. So 1 in 20 chances of there being an effect. So it's not the most critical, but it's a kind of a standard measure that's used. So we're saying that at 5% of significance, the null hypothesis is rejected. So if you ran something 20 times, you would expect it to happen once. So as I say here, if 100 different samples of the same size were taken from the same population, only 5 of them would have the same result we found, or a more extreme one, given the null hypothesis being true, because it only occurs in 5% of cases. And you can run a test statistic, and you get a test statistic, you get a p-value, and you can have a p-value of 0.001. Great, there's a really small probability of there being a true difference between, we'll use the satisfaction with care again, there's a really small probability of it not being due to chance, but at the same time as having statistical significance, we also still need to think about what's clinically important. So statistical significance is not the same as clinical significance, so we need to look at the size of the effect at the same time. So we use it in collaboration with our p-values and so on. We look at the difference that we've actually found between the two. Using 64 versus 68% satisfaction of care, is a difference of 4% actually measurable and of significant difference? Now, we might find no significance, and that might be because no real difference actually exists, or that the difference does exist, but the analysis that we've done doesn't have enough statistical power to detect it. So this often happens when there is skew in the data, or when a sample is too small. So I've talked around confidence intervals and tests and so on, but let's go back to specifically interval ratio and numerical data. So when we have continuous or discrete data, we're looking at examples of height, pain severity, things like this. We have two main types of analysis. So we have parametric approaches or non-parametric approaches. Now, as the name suggests, parametric analyses are based upon the foundation of parameters. So has everyone heard of something called the normal distribution? So we have a bell-shaped curve that shows the shape of our continuous data, and that is underpinned by a mean and a measure of variability. So a standard normal, for example, is 0, 1. We have a mean of 0 and standard deviation of 1. So just to flick ahead, so we have a nice bell-shaped curve here. We have our mean in the middle. We have equal variability either side of the mean. And that would be suitable to do parametric. If we had data that looked like that, we can use parametric methods. However, data isn't perfect all the time, and sometimes we have to say that the assumptions of the tests that we want to use are not met, so we fail our assumptions of normality within the data, and we have to use parametric analyses instead. So this very often happens when we have skew in the data. So there are different types of tests that we can do, but I'm going to just have a look at parametric analysis for now. So we're thinking about continuous data. We're thinking about differences between two groups of interest, and we're saying, yeah, we've got an effectiveness of a difference of, say, 4%, or a difference in pain scores of 3, or so on. So how do we actually test that? So the most simple way of testing that is using a t-test. Some of you may have heard of this before, some of you may have implemented these. But essentially, t-tests are a quite simple inferential test that can be used to test for a difference between means of continuous data. So essentially, all it is doing is taking the mean in one group versus the other and dividing by the variability across the two groups. And that gives us a test statistic, which then with something called degrees of freedom we use to get our p-value. And degrees of freedom are essentially how many points of variability can there be until it has to be fixed at the end, but it's not important for now. Really, all I'm trying to hone in on is that we've got continuous data. What's the most simple way of analyzing this? So t-tests. There are different types of t-tests that we can carry out, so it depends on the structure of the data. So if we have males versus females, they are clearly independent groups. We can't, they're clearly independent because they're different sexes, but we can also look at paired designs of data. So for example, we may have a clinical trial of some kind where we're looking at the effect of drug A. We have a washout period, and then we get the same person to have drug B. It might be advantageous because we are minimizing the variability between the groups, because we know it's the same person in both cases. And then in that case, because we have shared variability between them, we can use a paired t-test. As I say, it's only suitable in cases where we have parametric data, so where we have data that does follow this normal distribution. And there are cases where you can be slightly lenient with this because you do lose some power using non-parametric measures anyway. So there is a trade-off sometimes to using them, but if the data is clearly heavily skewed in one direction, you can either transform the data potentially or use non-parametric equivalents. But essentially, we're calculating a test statistic and getting a p-value. So we'll say difference in pain scores between males and females. So we've got 398 females and 331 males. The mean scores of 60.16 for females, 57.22 for males. So we have a mean difference of 2.94, as I said before. We also need to know how much variability within these measures. The smaller the variability, the more precise the estimate is, which we know, and that helps with the power of our analysis. Here we have a variability around the score of 60.16 of 14.28, and around 57.22 of 13.77. So some variability, but not too much. So using all of this information, we need to know the size of each sample group, we need to know the means and the standard deviation, and there is a formula for this. I haven't brought it up to show you because realistically, you won't go away and do this by hand yourself. It's very easy to implement in software, but it's just to give you an idea of these are the integral parts of carrying out this test. So size of each group, the scores in each, and the variability within each group. This would, if we went into SPSS or Stata or R or whatever is your statistical package of use, you would get a t-statistic of 2.81, 727 degrees of freedom, and we will get a p-value of 0.005. Great. So we're below our threshold of 0.05 because we've got 0.005. So we've got evidence of a significant difference in pain scores between males and females. And as I mentioned before, we have the same confidence interval of 0.89 to 4.99, around our difference of 2.94. And as I mentioned before, this is all above zero. And I kind of alluded to there being a relationship between confidence intervals and p-values. And when you construct your confidence interval, you are specifying a level of alpha. And that is also the same threshold that you use in your statistical test. So where you see a significant p-value, you would also find a confidence interval that sits either side of the mean in this case. So if we expected there to be no difference between the two, our confidence interval, our 95% confidence interval, would include no difference, which would be zero. So because our 95% confidence interval sits entirely above the effect of no difference of zero, we have further evidence, and also a p-value is great. We can say this is a measure of statistical significance. Yeah, we've got a significant finding, great. What the confidence interval does is it gives us that precision that goes alongside this. So we have t-tests, which are great, and they're useful in calculating a quick difference and a check for significance between two groups for a continuous outcome, but they are quite limited in adjusting for other factors that might be influential in measuring the difference that's being displayed. So if we think of two different examples here. So we might be conducting a clinical trial, and we might want to look at the difference in pain scores between usual care and some kind of intervention. Let's say it's patients with back pain and they're having back massage therapy or something. And we want to look at the difference between them. But we might expect there to be differences between older versus younger patients and also males versus females. Well, we could look at them separately and say, oh, are pain scores different between usual care and intervention? Are they different between the age groups? Are they different between the sexes of the participants? But if we were using t-tests, we would have to do those independently of one another, and we don't get a singular model of effect. So another example is in epidemiological studies. We might want to identify factors that are associated with our outcome of interest. So we might be interested in looking for potential prognostic factors or predictors. So, where do we go from t-tests? So, as you may have guessed, linear regression. So, it's a step on from a t-test by allowing for the inclusion of these other variables that have been collected. And whilst the outcome that we're modelling must be defined as being continuous, because we're still looking at a mean difference between two groups, say, the predictors that we're including within the model can take different forms. So they can be a binary outcome, male versus female. It could be age. It could, as a continuous measure. It could even be, you could categorize age into age groups, say 18 to 40, 41 to 60, and whatever may be your fancy. And then like region factors as well, which have no order to them. So although we're using linear regression to look at the effect of a difference in a continuous outcome, we can adjust for other types of variables and look at the effect of those on our outcome as well. So what we want to assess, essentially, is whether X and Y are associated. So, for example, is an increase in Y related to an increase in X? Such as, is maternal age associated with fetal birth weight? Do we expect that as mothers get older, that the birth weight of the child also increases? Does it decrease? Does it stay the same? If it stays the same, we have no effect. We won't have a significant finding for our effect of maternal age. If we do find a significant effect, well, if it's a positive coefficient of effect, we know that as age increases, fetal birth weight increases. If it decreases, if it's a negative coefficient, we know that as maternal age increases, then fetal birth weight decreases. And here on the left-hand side, you can see birth weight and age, and we can see, all of these dots here, this is a scatter plot of some data, and we've got a line of best fit through there. And that's essentially what we're trying to do, is we're trying to find the best linear trend through the data that we can. And as you can see, we've got a slight upwards trend, so this is saying that as age increases, there is a slight increase in birth weight. Visually, do we know how much of an effect this is? No. So we will carry out our linear regression and we will get measures of significance from that. Those being p-values and also confidence intervals as well. So how do we define these models? So we're interested in a model of the form yi, which is our outcome of interest. We have alpha, which is our intercept value. So if we go back, it's where we intersect with the y-axis. We then have our beta xi. So beta is the slope of the line for a value of interest, and then xi is our variable of interest. And then E is a measure of residual error that we've got from the model, because we aren't certain on all of the data. There is some amount of error that's going on within the analysis. So if we go back to the previous example here, so we would say that our outcome Y is fetal birth weight. We would say that beta would be positive because we've got an increase over time, and then we have xi as the maternal age. So I'm just showing you this just to give you an idea, essentially, of what is going on, and then when you then see output from statistical programs, this is essentially an idea of what is being shown there as well. But visually, as I say, what we're trying to do is we're trying to fit a nice linear line through the data that best explains the trend between X and Y. So here, we've got a nice straight line that fits through the data. There's a clear trend going on. It's essentially all we're trying to do. So, as I say, we've got this model, and we've got different parameters that are being estimated there. So we would be interpreting both the alpha and the beta parameters. And this is what you will see within SPSS output and so on, is values for each of these. So we'll say the outcome is blood pressure. So alpha plus beta times age. So age is our variable of interest, and outcome being blood pressure. So alpha, this would be the expected blood pressure for a patient with age 0, because our reference age is 0. We're then looking at the increase for every unit of age. So every additional increase in year of age, how much does blood pressure increase by? And that is what beta is telling us. So it's the expected change in blood pressure for every 1 year unit increase in age. If we use the fetal birth weight example again, so we could replace blood pressure here for fetal birth weight, that's our outcome of interest. We have an intercept value, which would be the value at a mother of age 0. Whilst that doesn't make sense, it's what's formulated within the model, because it's where the model extrapolates back to age 0. And then our beta coefficient would be how much the outcome would change for every unit increase in maternal age. So with t-tests, I mentioned that we have an assumption of normality within the data, and there are different assumptions that we also have to make here with linear regression. We have to make quite a few more because it is a more sophisticated type of analysis. So the assumptions that we make are linearity. So we're saying that the relationship between the predictors X and the outcome Y is linear. So we're not expecting there to be a curve in the data or some kind of parabolic shape which dips and then increases over the X-axis range. We assume that there is normality of the errors. So the residual difference between what the model is predicting and the actual data is our residuals, and we expect that to be normally distributed. and this is important for inference. We also make the assumption of independence, that observations are independent of one another. So if we go back to one of the previous slides and we have our data points here, we're assuming that all of these are independent mothers. And then we also are interested in having homoscedasticity, which is that there is constant variance across the whole of the X range. We don't want there to be less variance or more variance in one part of the scale than the other. But we want to know as well, is the model a good fit? So we want to check whether our model is an accurate representation of the data. And then we want to make sure it's good because we want to understand if the model is generalizable. We're doing this analysis for a purpose. We want to know, can we make inferences beyond the sample? We're fitting a model that is fitting a linear trend through the data that we have, but what happens outside of the ranges of the data? Does it make sense? Would we expect fetal birth weight to continue increasing past mother's age 35 if we only had age 35 mothers, up to age 35 mothers, for example? So I have to think about, is the model fit good? Is it a good representation of the data? And is it generalizable? Does it make sense? So one thing we would want to do is also check for outliers. So here is just a simple image to kind of make the point of how much of an impact an outlier can have. So we have our black line, which could have been our original analysis. So we could have just got our data and thought, yeah, this is great, let's fit a linear regression to this. And yep, okay, we've got this line, it looks like it fits nicely to the data, but we've got this outlier value here, which is really far away from the main chunk of the data that we've got. And what you can see this is doing is it's dragging this line down. So when we remove the outlier, so we ignore that red point, the data then is a great fit here between where the majority of the data actually is. When we have this data in the analysis, it's pulling it down. And this can often be corrected by having a visual look at the data to start with. If you did a scatter plot to begin with, you would get an idea of potential outliers and so on. When you look at ranges of outcomes as well, you might pick up on it then. So it's always good to have a look at the data before doing all of these analyses as well. But this is just to show that you have to be careful with these analyses, you have to be careful with your data because simple outliers can make an impact. I mentioned linearity being one of our assumptions. So I've just mentioned scatter plots looking for outliers. Well, we can also check for linearity using scatter plots as well. So we want to make sure that we've got a nice linear trend between the data. On the left-hand side, this is really, really good. We can see, as you can, if you follow my my laser pointer, that you can see we've got a nice, clear trend, linear trend through the data. However, on the right-hand side, we would have arguably a non-linear effect. So we can see that across this first part of the x-axis here, we have somewhat of a linear trend here. But as we get to further along the x-axis, the y values don't increase at the same rate as they do in the first period. So here on the left-hand side, we're saying that for every 25 increase in x, we are getting a 25 increase in y. And that's consistent across the whole range, so we have a good linear relationship. Whereas here on the right-hand side, what we have is that, to start with, we have the scaling's a bit off on the x-axis, so let's just say 5, 10, and 15. So an increase of 5 corresponds to an increase in about 150, but an increase in the next 5 only corresponds to an increase of about 25. So there's clearly a non-linear trend going on here. So this obviously isn't a suitable analysis to carry out on this data. How do we check normality? So again, we're looking for this nice bell-shaped curve. We can see here we've got a nice overlay of what a normal distribution would look like over the data to compare to. And we can see that, yep, this is symmetric around our residual mean of 0. There's good spread, it's symmetric, it follows a bell-shaped curve. That's fairly good. We're happy with that. However, on the right-hand side, we can see that it's poor. We've not met our assumption of normality in the residuals. The mean is here. We have the bulk of the data, yes, okay, is above 0, but we're heavily skewed all the way down to -6, whereas positively it's only 2. So there's a big disparity in the data and in the residuals. So the model clearly isn't fitting as well as we wanted it to. Independence is another assumption, as I mentioned. And as I say, we want to make sure that all of these points are independent. So to do this, what we're doing is we need to plot each of the points against the predicted model values. And we would expect there to be a random scatter around the midpoint of 0. If there is a random scatter, then we know there's independence. However, as you can see on the right side, where we're plotting our predicted values against the errors here, there's some kind of trend going on here. So there's obviously some dependency in amongst one factor that we've got in our model, which is causing this relationship to occur. And again, fails our assumption, so the test isn't suitable. And then finally, we have our constant variance. So on the left-hand side, we're checking that the residuals have a common variance. So across the range of predicted values, we see that there's a nice spread either side of 0, whereas on the right-hand side, we see that for lower predicted values, there's less error. As the predicted values get higher, there is increased amounts of variability, so we don't have constant variance across the range of predicted values. So again, something is happening within the model. It might not be a good fit to the data. So coming to the end of this set of slides, I've gone through kind of like descriptive analysis, t-tests, and what we would call simple linear regression. But what is probably of most interest is extending to multiple regression. So simple linear regression for an outcome y and a covariate x can be expanded to include multiple variables of interest. So if you think back to one of the, I'll bring up the slide. So we have our simple linear regression shown in this form. So we have xi here, which is one outcome of interest. However, what we can do is we can extend this to include multiple variables. So we can say, okay, for fetal birth weight, we have our intercept, we have the effect of maternal age, but we could also then look at the region that the mother comes from. We could also look at the sex of the baby as well. And in combination, we can then look at how they all together impact the outcome. So we're not saying that the effect of xi on yi, we know that this isn't going to account for all of the effect. So we want to include other variables that also can add to it. Now, we can add as many other variables as we would like, but they need to hold some kind of importance, and we can check that by looking at something called R-squared statistics, which tell you the amount of variance that the model explains within the data. But if I just go back to multiple regression, so our alpha is the intercept, and that's the value when all of the covariates that we then have are 0. So in SPSS, for example, we would have a coefficient value for all of our variables of interest. So maternal age, region, baby sex, for example. When they are all the reference group, the fetal birth weight would be what our intercept value is, our alpha. Each covariate then has its own coefficient, so that we know the effect of each of them. So x1 for maternal age, we know whether that has a positive or negative effect, and the size of that coefficient, the size of that parameter, tells us how much of an effect it has on fetal birth weight. Similarly, for each of the regions, they would have their own effect. Some may be positive, some may be negative. And again, the size of that coefficient tells us how much of an effect it's having. And then for xn variables that you include within the model. But we need to interpret the outcome given all of the variables within the model. We can't just ignore the other variables and say, oh, this is the effect of one. We need to say that it's actually within, or in the presence of all of the other data. variables. So something else just to touch on is something called dummy variables. So these are categorical variables that are non-numeric and can relate to 2 or more groups. So an example of this would be something like stage of cancer, so stage 1 through to 4, for example. When we are modeling for categorical predictors in the model, we need to use dummy variables to be able to distinguish between the groups that we have and then estimate an effect for each of them directly. So as I said, if we're using fetal birth weight again, maternal age would just have a singular coefficient. For every increase in maternal age every year, we know the effect that it's having on the outcome. But for region, for example, we need a dummy variable so that a coefficient can be calculated for each of them. So within the model, we would specify x2 as being region. Mathematically, we would need x2 to be region 1, x3 to be region 2, and so on. So in SPSS, that's kind of, you have to construct these things sometimes as well. So for the intercept, when it's included, a dummy variable for all but one of the categories is needed. So for example, if we do male versus female, we would specify one as our reference group. And we would say then fetal birth weight is the outcome, females is our reference group, so then we would have a coefficient for males. So then we would know how much of an effect being male is on fetal birth weight versus female. And that's essentially how we use the coefficients to compare groups. So for a variable with k categories, we need to represent k minus 1 dummy variables. So a binary variable is just a single dummy variable, and then we get beta coefficients for each of them. So finally, so why do we want to use linear regression? Well, we're trying to describe which variables are associated with the response of interest. We also want to be able to adjust our analysis. So we're looking at the relationship between a response and a particular factor. So having adjusted for other potentially confounding factors, we want to look at the effect that is going on in the presence of these other factors. So for example, it may be that smoking is not associated with blood pressure levels once alcohol consumption is accounted for. We may have carried out a t-test between blood pressure levels for smokers versus non-smokers and found a significant effect, a significant difference between the two. However, when you then incorporate a confounding variable, such as alcohol consumption, it may be that actually the alcohol consumption is what is accounting for that difference, but it was previously ignored in the t-test because you didn't adjust for it. Multiple linear regression can also be used to predict. So we're trying to fit as good of a model as possible. So we decide upon a final model with a final set of included variables, and then we use it to predict a response for a new individual given their set of variables. So we know what the parameters are for each of the coefficients. We know whether it's a positive or a negative increase for being male or female. We know, again, the same for age, for region, and so on. And if we have a good model fit and we're happy with the generalizability to our target population of interest, we can then collect those same variables that are included in the model on someone else. We can get someone's sex, someone's region that they're from, someone's age, put them into the model using the coefficients that we've got and predict what their outcome will likely be. So we get an expected response, which then we can then say, okay, well, this person's expected to have a high risk of a heart attack, say, because they have presence of negative behaviors that are associated with an increased risk of a heart attack. So you can say, yes, we know that you smoke, we know that you drink, and we know that you eat fatty foods. Say, for example, you've got an increased risk of a heart attack, so you can then implement a decision towards their healthcare at that point using that prediction model to then help someone's health outcomes in the future. So you're using a model to predict what's going to happen and implement changes from there. And just the final point to say is that regression is great. It can tell us about associations between variables, but it does not necessarily imply causation. We aren't saying that variable X is what's causing the effect on Y. What we're doing is we're looking at the association between the variables. To look at causality, you would have to carry out a formal causality analysis. So those are my slides. What I plan to do next is just kind of go through SPSS a little bit and just have some examples of what how you might do this. I am not an SPSS user much myself, so I am going to do my best. I'm going to try and get some output, and I am going to try and talk through exactly what we're looking for and what these outcomes might be. I've got some dummy data to look at, but I've been talking to you for maybe 50, 55 minutes. I've got a very dry mouth, so I'm just going to have a couple of minutes, if that's okay, just to have a drink and rest my throat for a second. So yeah, if you just give me 2 minutes, and then I'll crack on with a demonstration. I guess before I do that, does anyone have any questions? I've spoke a lot to you all. You know, I've gone through a lot. Please ask me questions. You know, don't sit there being confused about anything or wondering anything else. Is there anything that you want to know more about? Is there anything that you don't feel I explained very well? Is there anything you want me to revisit? If not now, please hold on to those thoughts. Please come and get me on at any point in the rest of the conference. If you want me to ask me any questions, do come and find me. I'm happy to help with anything. But if no one, doesn't look like anyone's got any questions now, so I'll be back in 2 minutes. Thank you.
Oh, sorry, I didn't see. But I was wondering whether they might also, maybe after this, want to take like a 5 minutes break.
Would everyone like a proper 5-10 minute break? Would that be better? People have got a chance to stretch their legs. Would people prefer that? Let's have 5 minutes. Let's come back at 20 past. Is that okay?
That, because we'll be referring to some of the things that you've covered. So whether it makes sense or not at this point, don't worry. Maybe when you start trying to see, for instance, when explaining what a p-value is, because I know that's one of the things that can seem very abstract initially, and more so given that you're just being introduced to hypothesis testing, trying to get your heads around what a null hypothesis is, where there's no significant difference between groups. But maybe when you have an actual output from SPSS that you've carried out, and you are trying to see how to, or what SPSS would present to you as the p-value, or what it refers to as significance, then you'll begin to maybe make some sense of it and try to see how you might be able to take forward what you'll have covered today. So in the next part of the session, Kiran will just take you through some kind of demonstration in terms of how you do this in SPSS. I believe most of you have SPSS on your computers, on your laptops. How many of you have SPSS? Maybe just with a show of hands. 1, 2, 3. So some of you do, some of you don't. So what we'll do both for today's session and tomorrow's session, we'll have more of a demonstration where we'll be taking through, this is how you do it in SPSS. I don't know if you've been introduced to SPSS syntax, where you can put the commands in terms of what, because SPSS is very user-friendly. You can just use the menu, select what you want to do, and ask it to run it. Or alternatively, you can ask it, rather than run it, paste it onto what it's referring to as a syntax so that you have the set of commands. That can be sometimes very useful, just to keep record of what you are doing and then run it from that. So going through those kind of sessions will enable you to see how you do it in SPSS, what kind of output you come up with, how SPSS presents this to you, and then having a discussion as to how to interpret it. It's just to see how to make sense of what you get from SPSS. And following today's session, tomorrow we'll build on that, moving from what you are covering today, which is linear regression analysis, where your outcome is a continuous variable, because you had covered the different variable types. Then tomorrow you'll look at cases where, for instance, if your variable is not continuous, where you are not able to carry out linear regression. Quite often we have outcomes which is, say, alive or dead, so that it's not a continuous variable, but it's either one or the other. Those ones we use a different type of analysis, so we'll be able to take you through how you do that. But for now, I'll hand over back to, sorry, I didn't give you a chance to say whether or not you needed a break, 5 minutes, or we just want to carry on and finish earlier? Yeah? Continue, okay, that's great. So I'll hand you back over to Kiran to take you through SPSS, and hopefully that will also be more interactive in terms of you beginning to try to see how to make sense of the outputs that you obtain, whether it makes any sense to you. Do feel free to raise up your hand if what we are saying is not making much sense to you, and we'll take a pause and try to go through it over again, just for us to be able to make sense of what we are covering. Thank you.
Okay, so if we're just going to carry on, am I okay to have my, fantastic, thank you very much. So on the screen, I have just opened up a blank instance of SPSS. So I've got some dummy data on birth weight, which I sampled from some of the maternity data that's been collected that I was referring to earlier in my data quality assessment. So let's bring that data in and let's start to have a look at that. So I'm going to import data. So it's in an Excel file, and I called it automate dummy data for SPSS. So we're importing this worksheet here. There's lots of different things you can specify to start with, but the main thing is making sure that the variable name that I've got within Excel in the first row is taken as the column names, so that then I know what each variable refers to. So if I click OK, I'll import that data. And in SPSS, we get two main views. We have our data view, which shows you all of the data, as the name suggests. And then again, as the name suggests, variable view, which describes each of the outcomes. So within this sample data, I've got baby ID, which is just an identifier from 1 to 200, so we just know which baby's which. We've got an outcome of interest. We've got baby weight, so this is birth weight. We've got the baby sex. We've got gestation, so this is weeks at time of birth. We have delivery mode, and then we have whether they were a preterm birth or not, whether they were born earlier than 37 weeks or not. So these variables are, the type of variable is underneath measure. So if I just flick back to the data, you can see that I've got them all listed as codes. So whilst this is fine for baby ID and birth weight, for example, because ID is just a continuous count variable, that's fine. Baby birth weight in grams is our outcome. I've used coding labels to know what each of these are. So I've got a notepad for each of these. So baby sex, so 0 is a male, 1 is a female. For gestation, that's fine. We know that's a continuous variable. Well, it's discrete because it's counts of weeks. Delivery mode, we have 4 different categories. We have normal, spontaneous vaginal delivery, C-section, and breech. And then preterm, those that are less than 37 weeks or more are not a preterm. And then a 1 is where a child is preterm, so they're less than 37 weeks. So first thing we would want to do is have just a descriptive look at the data. So let's go to, I think it's descriptives, which makes sense. So yeah, analyze, descriptive statistics, descriptives. And we're presented with this box here. And what we do is we just say, okay, we're interested in this variable. We know it's a scale variable because in SPSS it's got a little ruler symbol to it. And we drop that in there. So this is the variable that we're going to compute our descriptive statistics on. And then we have various options. So we've got the mean, we've got a measure of standard deviation, we've got the minimum, maximum. We can look at the variance, which is the square of the standard deviation. We can put the range on, and also the standard error of the mean. We can also look at the distribution, so we can look at kurtosis and skewness. I'm not sure what these give you, so let's put skewness. Oh, I'm so sorry. How can I? Let's have a look at options. View. That's more so. Is there no, there's not a zoom option at the bottom, no, so yeah, it is, so yeah. I'm just wondering, I thought it would just been like a option to then, let's just split in, yeah, I'd know. Edit, view, are there more options under there? Okay. I will do my best to talk about what is on the screen. I didn't realise, sorry, that you can't really see. I'm just going to have a quick Google to see if I can zoom in SPSS. Too small on the screen. I don't know if you can. zoom in, yeah, that's an option. Could you do that, or it could... Oh, that could be it. Try 18.
Let's see if we go to this.
Yep.
18 also.
Yep. And then,
Let's just try and see.
and then apply.
And then
Not made any changes. Maybe I'll tell you what I'm going to do. I'll try. If I increase the scale, if I increase that to 125, what will that do? Right, it's a bit better. Let's do 150. That'd be good. Is that better? Is that more readable? I'll try 200, but I'm not at 175. But I'm not sure how much will fit on the screen. Let's. Okay, right. We can use this. That'll do. So sorry about that. I could see it nicely on my screen. I just assumed you could see as well. I apologise. So we have, baby ID, baby birth weight, baby sex, gestation, delivery mode, and preterm. So hopefully you all managed to catch all of that. So they are all entered as numeric values. We can add labels to them, but I'm not going to sit here and do that in everyone's time. But essentially what you would do is you would go in here and you would add the labels to say that 1 equals female, 0 equals male, I think was the way that I had it round. What did I say it was? 0 equals males, 1 equals female. So you would just say, you would just type that in, and then you can switch in here. You can flag it between the values and the labels, but I've got no labels, so it's not changed. So let's do some initial descriptives then. So analyze at the top, descriptive statistics, and then descriptives. And we get this pop-up window. So we have our variables on the left-hand side here that we're interested in, that we've got, that we've imported. We can see that baby ID, baby weight, and gestation are scale variables because they've got the ruler that denotes that. And then baby sex, delivery mode, and preterm are categorical variables because it's got this little symbol that denotes groups. So if we just take baby weight to start with and just look at this descriptively, options, let's see what options are available. So we have, we want the mean because we've got a continuous variable, so let's get that. We want the standard deviation, we want to know how much variability there is around that. Minimum and maximum, we'll also add the range, and then let's see what this gives us. Click continue, and then let's click OK. And then SPSS then opens that in a separate window. So we can see we've got 200 cases, so we've got no missing data because I expected there to be 200 rows. The range is 3,900 grams, so 3.9 kilograms, with the minimum being 1,100 and the maximum being 5,000. The mean within this group is just shy of 3,400 with a standard deviation of 640 around that. So, yeah, okay, we've got some descriptives there. That's just a general measure. Now, I'm trying to remember how to, I want to look at this by group. And is Monica still in? Monica? How do I do a descriptive by group? I forgot.
Before you run the descriptives, then it will do it by that group.
Okay, so a split file.
Data.
Yep, so data split into files. I can't go any further down. I can't screen. It's because I've zoomed in so much. Okay, I'll do a t-test because that would give it, wouldn't it?
Okay, yeah.
Yeah, right, okay. So I was going to try and do it by group, but what I'll do instead is I'll jump the gun a little bit and look at it into a t-test. So let's say that we're interested in the difference in baby birth weight between males and females. So we're going to try and analyze this. So to carry out a t-test, we've got means, so we want to compare means. So do we have independent or paired data? If we're looking at males versus females, which do we have, independent or paired? Have we got independent or paired data? If we're looking at males versus females, are they independent of each other, or is it a paired design? Independent? Is that what you said? But yeah, so it's independent data because they're not the same person. We're not collecting two sets of data on the same person. We've got one score for one person, which is male, one score for another, which is female. We can't get the same for both male. You know, a baby is either male or female. So we've got two independent samples. So we've got an independent samples t-test, which prompts us with this menu. So what variables are we trying to test? So we want to test our baby birth weight, and then we've got our grouping variable. So this is the variable that we want to look at the difference between. So we're going to take baby sex and add it in here. So it's asking me to define groups. So group 1 is male, 0, and group 2 is 1. Let's say that, because they're the values that I've got within the data. So 0 being male, 1 being female. Let's look at what options are available here. So let's add a confidence interval. So I'll set this as the standard of being 95%, and then I'll get you to have a look at that with me in a moment. And then I believe it's pretty much what we want to start with. I don't know if there's I think it automatically must give me mean differences. So let's click OK and see what that gives me. Okay, so yep, here we've got at the top, we've got our descriptive statistics by the two groups. So baby sex 0 is male, 1 is female. We just so happen, by chance, I didn't do that on purpose, to have 100 in each. And we see that males on average weigh 3,353.8 grams, and females weigh 3,427.5 grams. There's more variability within males compared to females. There's 766 versus 480. And the standard error, which is the amount of deviation divided by the size of the sample, is also bigger in males versus females. So as I said in the slides, to carry out a t-test, there is a formula, but you don't need to know that formula. You just need to understand what goes into it to be able to calculate it. So we have our counts within each group, we have our mean value, and our standard deviation and standard error, which goes into the formula. So we get a t-statistic of minus 0.814 with 198 degrees of freedom. We get a p-value of 0.208. So what does that mean? A p-value of 0.208. So are we? So what's the threshold for significance for a p-value? So in the slides, I said that we typically 0.05 is used. So we have in 100 cases there would be 5 that it's not due to chance. So 0.05 is our threshold. If we've got a score if we've got a p-value that doesn't surpass that threshold, do we think we have a significant or non-significant finding? So because we're above 0.05, so the probability is 0.2. So okay, so to have a significant finding, we want a p-value that surpasses the threshold. So we're essentially trying to find out the probability of the difference between the two groups being due to chance or not. So the lower the probability value, the less likely it is that the difference that we're finding is due to chance. So in this case, we have a difference between the two of, where's the difference? A mean difference of 73.7 grams, which in reality is a small difference. So we're not really going to expect there to be much of a difference. So our p-value of 0.208 doesn't go past our threshold for significance. If it was, say, 0.001, we're saying then that there's a really, really small chance that it's not some random finding. But because this is not gone past that threshold, we're saying actually in this data we've not got any evidence of there being a significant difference between the two. And as you can see, with a small difference here of 73 grams and quite a lot of variability around the scores as well, that is to be expected. And at the same time, we can also get our confidence interval around the difference. So it'll be symmetrical around this minus 73. So the lower bound is minus 252 and the upper bound is 105. So the distribution for the population that we're inferring from, in 95% of cases, essentially, we're saying that the true mean population value difference between males and females of birth weight would fall in that range. So, yeah, we know that this falls within that range, but because this range doesn't include 0, we aren't saying it's either all below or all above. We don't have any evidence of there being a difference. So, independent samples t-test, really simple. I say really simple. It is to me. I apologise. It's the first look essentially at getting a statistical measure of difference between the two. We can calculate a mean difference ourselves, but using the variability in the data and the size of the data we've got, we can calculate these statistics, and then that gives us our p-value. And that p-value and the confidence interval are trying to give us a measure of whether we do have evidence of there being a statistically significant difference. So what would you take away from this? So if you were reporting this somewhere, you would say that we had data on 200 babies, and we were interested in looking at the mean difference in baby birth weight between males and females. We had n equals 100 in each group. The mean in group A for males was 3353, and for females was 3427, with a mean difference of 37.1. A t-test was used to test for a significant difference between the groups. However, no significant findings were found, as the p-value failed to satisfy the threshold of 0.05. So we don't have any statistical evidence that there is a difference between the two groups. How does that sit with everyone? Is everyone okay? I can try to explain things differently. If people have got questions, I can. I'm here to help. I can try to think of different ways to explain things. I thought having an example might help. Do people not feel? You got a question? No. Okay. we're trying to, we're interested in a continuous outcome. All we're trying to do is quantify with a measure, a probability measure. We're trying to say, okay, what's the chance that this difference that we're finding isn't actually due to chance? So all the p-value is a probability value. So we know it's between 0 and 1. If a probability of something is 1, it's certain. If it's very, very low, it's very uncertain. And we're trying to see how much the difference that we've got is due to chance. Smaller and smaller, the smaller and smaller that value gets, the less likely the difference that we're potentially finding between two groups, it becomes less due to chance. So we have a threshold of 0.05. So 1 in 20 cases would be due to chance. If we fall below that, well, if it's 1 in 100, well, it's even less likely due to chance. So there's a true reason between the two groups that we are finding a difference. Just so, it probably would have been better if I had an example that did have a significant difference, but I didn't test this data beforehand. But let's say then that we did have a difference of minus 600 grams between the two groups, and we had a p-value of 0.001. So we find a big difference between the two. We can say that on average males weigh a lot more than females do. Yeah, males weigh a lot more than females do. We've got a difference of 600 grams between them, and we get a p-value of 0.001. So let's say that happens. So what does that mean? Well, the probability of that difference being due to chance is 1 in 1,000. So that's a really, really, really small chance of that happening, which gives us confidence that the difference that we're finding between the two groups is due to the group difference that we're looking at. So where we fail to have a significant p-value, we fail to provide any statistical evidence that there is a difference. So this difference that we have here of minus 73.7, that's just due to chance. There's no reason to suggest that males versus females are different in birth weight. So that's a t-test. So I'm going to move on to regression. I'm hoping that this is starting to sink in a little bit, essentially what we're trying to do. What we're trying to do is we're trying to just move away from looking at things descriptively. We want to try and infer from our sample that we've collected to say, what do we know about the population? This is where the confidence intervals come from, but we also need to have a measure of the probability of the event being due to chance or not within the sample, which is where which is our p-value comes from. So let's minimize our output window and let's go to analyze again. And further down here, we have regression. So we have a continuous outcome, so we're using linear regression. And we are prompted with a different box now. So here we have our dependent variable. So this is what we're interested in. So this is our outcome. The measure that we're interested in that is dependent on the other variables. So we're interested in what our baby weight is. And then, for completeness sake, I'm going to show you that a simple regression is the same as a t-test. So if I put just one independent variable within there of baby sex and click OK, we should get the same as before. Yep. So we see we get the same difference, we get the same t-statistic, but we've got a slightly different p-value, but it's still non-significant. Oh, it's because of the constant term as well. But we still get the same difference. We still get the same coefficient going on. So we're still finding that there's no difference. But then, obviously, the advantage of doing this is that we can expand this a bit more. So, I mean, I don't know if this is going to show any difference, but let's just see how we would then expand from a simple linear regression to then a multiple regression. So very simply, we would go back here, so it still saves what we had before. But we know we can include other variables to adjust for. So, yeah, we had a coefficient for what the effect of sex was. We know it wasn't significant. However, we want to also think, well, does the amount of gestation affect the baby birth weight? We know it probably should. If a baby has been in the womb for longer, they've had more time to grow, so they should have a positive effect. So let's put that in. So now we've got two different variables. We're looking at the effect of both. So let's just have a look at that. So do we expect there to be any differences? Well, yes. So the differences between the males and females now won't be a product of just males versus females. It's also due to an effect of the gestational age of the child. So we have our coefficient table here at the bottom. So before we had a difference of 73 for a difference in baby sex. However, when we also have gestation within the model, we see that this is the effect of gestation is stronger because it's minimized the effect of baby sex. So we can't ignore baby sex. We know that it's still going to have a difference. So we know that because 0 is for males, we know that females will have 15.9 grams more body weight, birth weight. However, interestingly, we have our beta coefficient for gestation. So this is a discrete variable. So every additional week of gestation increases the baby's birth weight by 70 grams, which is quite significant because we're thinking about this as every unit increase. So if you reach 40 weeks gestation, that accounts for 2,800 grams of baby's birth weight. So it's a considerable amount. And if you consider 30 versus 40, that's 10 weeks difference. Well, that still refers to a 700 gram difference in baby birth weight. So we're thinking about what's the interpretation of these coefficients, what does it mean for our outcome. So whether you're male or female, this will still be the same effect. But if you're female, you also have this additive effect as well. Now, as I say, we expect this to be a difference. And as you can see, we've got a p-value which is less than 0.001. So very, very, very small probability that the effect of gestation having more gestation having a positive effect on baby birth weight is due to chance. There's very, very strong evidence within our data here that gestation positively affects baby birth weight. But at the same time, we also know the effect of baby sex as well, which still wasn't significant. And we can expand on this again. So we have other variables. So let's just drop another one in so we can see how things change. So let's put preterm. Now preterm's based on gestation anyway. So let's put delivery mode in. I'm hoping this works because I haven't made dummy variables. So let's see. Right, no, it's not worked. Can I do a different variable instead? Got baby birth weight on sex. Okay, what I'm going to do instead is I'm going to take gestation out, and I'm going to put preterm in instead, just to have a look at that instead. So this is a binary variable, so we're going to look at the effect of that as well as at the same time as baby sex. So let's run this analysis. So we get other output with SPSS as well. So we get an idea of what the model is, we get a summary of the model, we get something called an R-squared statistic, which tells us the amount of variance in the outcome that's explained by the variables. This is very low, so they're not good predictors of the outcome. But anyway, let's have a look at these coefficients and see what is going on. So we now have a different scale of effect for baby sex. We can see that we've got a positive effect of being female of a scale of 34, which is twice as much as before. And that is still independent of whether the child is preterm or not. But here, our reference group of preterm, so 0 is the child wasn't preterm, so they went past 37 weeks. And then it's a 1 if they did go below. So this coefficient is saying that if a child is preterm, that their baby birth weight is 434 grams lower. So we're saying, and again, we see a positive effect of this. We're saying that you know, this is a significant change in the scale of the outcome. We see it's a significant change and a positive effect. We've got a p-value which is lower than 0.001, so it's a very, very small chance that, very small probability that this is due to chance. Now, one thing I've noticed is there must be an option for our confidence intervals. So let's see if I can add them somewhere. That's statistics, probably. Here we go, confidence intervals, right. So let's rerun that model. Can we get some plots as well? Will that be good? Okay, let's leave plots for now. So I've just rerun that same analysis that we've just seen, except for now we've got confidence intervals included. So we've got the same significance values. We've got a non-significant effect of baby sex, 0.69. So there's a really, really, really high probability that this is due to chance. This difference is a small difference anyway. And we know we've got a really small probability value here. So we're saying that the probability of this difference being due to chance is very, very, very small. We set our alpha level was at 0.05, and then this corresponds to our 95% confidence interval. And given that we have a non-significant result here, our mean difference of 0 in our outcome between the two groups falls between the ranges of the interval. So if you imagine that we have our nice normal distribution of our outcome data, for this effect, 34 would be in the middle, and we've got negative values either side. However, for the same outcome, the effect of preterm is very significant, and as such we see a confidence interval that both of the bounds fall below 0. So in 95% of cases, essentially, we are saying that the true population effect of being preterm would fall somewhere within that range. So we've got a range of around 200 grams either side of that mean estimate. So we're saying that, yes, we've got evidence of a significant effect of the child being preterm. We also know that in 95% of cases that it could be as little as 244, but also potentially up to 623 grams difference, which is quite considerable, really. And then I guess one last thing to mention simply is, you know, I mentioned prediction towards the end and how you could use this. So let's use these coefficients here using, let's try and say for a child that's come in, very simply, we've got a female baby that was preterm. Actually, let's start with a male that wasn't preterm. So both of our categories are the reference values. So a male baby that wasn't preterm would have an estimated birth weight of just shy of 3,500 grams, as you can see. So our constant, when all of the variables included are the reference groups, when they're all 0, is this intercept value. We then say, okay, we've got a female birth, so we add 34 to that, so it's 3,550. But then the child is also preterm, so we take 434 off that, so it's about 3,100. So we can then say that if we had a female preterm baby versus a male term baby, that we would expect to see a difference of 400 grams between them. So we're trying to use this model to predict the baby's birth weight, for example. It's not a good model by any means, but essentially that's what we're trying to do. So I'm sorry that I can't add other variables to that to explain dummy variables a bit more. I know that Monica tomorrow, when she talks about logistic regression, will perhaps have a little bit more time to go through that as well. I'm going to be honest, I feel like I've lost some of you in the room, and I do apologise. I'm sorry if I've not been clear. If there are any questions, please do come and ask me. I can try as many times as I can feasibly think of to try and explain things, because this is important things. It'd be good for you to know if you can take data and analyse it, and then you can you know, if you understand how to interpret this data and so on moving forward, then it'd be great for advancing your analysis and your research and so on. So please don't hold back. Please come and find me at any point if there's anything that I've not been clear on. I know I've been talking for a while. You're probably sick of hearing my voice. I've talked a lot today, so I do apologise. I don't think I'm due to talk again, so you know, that's probably good for all of you. But yeah, that's enough from me now. Monica, would you like to say something?
Thank you very much, Kieran. Yeah, I know we've given you a lot of information today, and maybe it will take time just trying to digest that. And we are hoping by tomorrow, when we move on to logistic regression, which, as I said, is a different type of regression, which normally we would use when our outcome variable is not a continuous variable. Quite often we want to find and work with an outcome. For instance, Kieran mentioned, say, premature delivery. If you wanted to look at what factors are associated with premature delivery, because it's either premature or not, then we can use logistic regression. If you want to find out what factors are associated with, say, something, tomorrow we'll use an example of, say, C-section, where you want to find, because a woman either delivers through C-section or not, and you want to find what are the factors that are associated with that. We'll be able to see how we use that. We use logistic regression to be able to determine that. So we'll move on to, we'll build on what Kieran has covered today, introducing you to regression analysis, which I know was a lot, particularly given that we had to start from the basics, trying to explain some of the concepts like hypothesis testing. Those I know normally take quite some time just to get used to. But it's one of those concepts that when you are reading any scientific paper, probably you've come across this, where somebody would say this factor was highly significant, and you're trying to establish how was that, how did they establish that? You'll be using the same measures like p-value, which tells you the extent to which a particular factor was significantly associated with a particular outcome that you are interested in. So I know we've given you a lot of information today. It takes some time to digest it. Tomorrow we'll try to build on that, and as things get, as we go by Friday, we'll have an opportunity to work in groups where you'll be able to hopefully see how you can use these concepts in your own analysis, and trying to work in a group to try to make sense of it, try to see how whether you can produce this output and try to interpret it, because the main aim is we are hoping that by the end of the workshops, you'd be able to have an analysis, look at the analysis and be able to make sense of it, be able to interpret it. That's what we are hoping by Friday we'll be able to achieve. So thanks so much for listening, and we look forward to continuing with the discussion tomorrow. And hopefully by that time, some of the concepts will be familiar, and we'll be able to be more kind of interactive, such that rather than us giving you more and more information, today was mainly that because we needed to introduce the concepts first, but then once you are familiar with the concepts, then hopefully you can try to begin to make sense of it. If it's not making any sense to you, tell us, and then we'll see whether you can reframe it in a different way such that it makes more sense to you and you're able to see how you can use it going forward to interpret the analysis that you carried out. Otherwise, that's all for today, and we look forward to continuing the discussion tomorrow afternoon after the morning sessions. See you tomorrow. Thank you. Hello, sorry, I should have said this. So that ends today's session. So we are free to go for tea, I think, in the same place. And then after that, we can leave for today and come back tomorrow morning to carry on. Thank you. I think we're good to go. Yes.